Hanji, so very good evening everybody, good evening, and it is such a pleasure to be able to connect to all of you today. I was waiting for everybody to join in so that nobody misses out. And let us now, I will give you a quick idea on what will we do in these classes and what is my goal for the this integrated sessions of radiology. So radiology is a like little super specialized kind of a branch, and it takes a lot of effort to integrate it with other subjects. So what I have seen is in the last few decades of my teaching that it has to be taught alongside clinical subjects. So this year what I'm doing is I will be doing with you on the app live sessions, short duration live sessions, give you time to assimilate. We will cover a lot of ground, and then what we'll do is I will, after that, in all the face-to-face centers, I will come for I have made a special test for all of you, and I'll revise everything again face-to-face also, so that you get every question right in the radiology section. So that is the idea. So first of all, because today is an auspicious day of Guru Purnima, and I see thousands of you have joined live on the app right now, and we could see the servers also shooting up because of the massive crowd on the app right now. So because I am so excited to teach you all. So what I will do is first of all we will give our gratitude to the God Almighty. We will be thankful to the God Almighty for giving us the opportunity to learn about the human body. I know many of you are I see many of you are already on the app. If you still are there, I see Dr. Deepthi, Aman, Astik, everybody. So happy Guru Purnima to everybody. And I would want you to first of all start with a positive notion. We are all grateful for where we are today. Okay. So let's start off by saying that we are all grateful for where we are today. You are all doctors. And the goal of my classes will be to teach you clinical radiology. I will try my best to do it clinically. I will not go theoretically. I will do it clinically. I will try my best that everybody understands, the concepts. And I will also be looking at the chat box, and I will be answering your queries in between. Also, towards the end of the class, I will be answering your queries, and I will be visiting, all the centers face to face, and again I will be taking your queries. My goal this time is to make sure that I am able to talk to every student possible, and that is where I'm trying to leverage all that I have to make sure that we are able to touch everybody. I am grateful for I want all of you to say that I see that word already by Zehra, attitude of gratitude, that I am thankful that I have been given this opportunity to teach you all. Thank you all of you for the opportunity. And second thing is, we will also always have hope. Okay, we will always have hope that we are going to do well in life. If anybody has these two things, gratitude and hope, they will always win. Gratitude, hope, you will always win in the life. Okay, everybody set to go? All set to go? Okay, now let's see. So first of all, my first topic of the class will be, I will try to integrate radiology and anatomy. I have already said that these short sessions that I have kept of radiology rather than doing a full day, because I want to cover one topic and give you time to assimilate, ask your doubts, then we will do another topic. We will do a lot of things system wise. I will look at brain, I will look at thorax, I will look at bone x-rays, I will look at different organ systems together. Okay, but I will go step by step in each class. Everybody ready to go? All set? Super. I can see a lot of rock stars already in the class. I am super excited, and I know you are all excited too. So we'll try to integrate radiology and anatomy. First of all, my first question to all of you is, are you aware of the word CT scan? Are you aware of the word CT scan? Yes, you are. You have all heard of this, and it forms one of the most often asked MCQ in the radiology section. And I am starting with the most high yield. My question to you is, if you ever have a doubt in your exam, what is the more important topic of radiology? Always think, what did sir teach first? Okay, So I will go in the sequence of importance in the class. I will cover everything. I will cover everything clinically as well as for your exams. I'll cover all the things. Okay. So first thing, CT scan, what does it mean is, it is a machine which has a shape like this. Okay. It has multiple X-ray tubes. Okay, everybody, multiple X-ray tubes rotating around the patient. Okay, CT scan has multiple X-ray tubes rotating around the patient, and the X-ray beam is coming at different angles, passing through the patient at different angles. Okay, so for those of you who have already attended my class, listen to it more intently, Simran. Okay, clear everybody? CT scan is a machine in which X-ray beams are rotating around the patient and taking images at different angles. Okay. Now you might ask me, sir, why do I need to know this basic thing? I am going to answer 2-3 questions for you. Everybody now, first topic of the class, first line of the class, I am saying you need to answer in the chat box. Okay. If a pregnant lady comes to you for a CT scan, will you do it or you will not do it? A pregnant lady walks into your hospital, says, "Mujhe vomiting ho rahi hai, I think I have appendicitis." Will you do a CT scan in a pregnant lady or not? Anybody? Anybody? The answer is contraindicated. Are you clear? CT scan is contraindicated in pregnancy. Can you tell me why? Because it is based on X-rays, and X-rays are ionizing radiation. X-rays are ionizing radiation. Now immediately they will ask you, can we do MRI? Can you do MRI in pregnancy? Can you do ultrasound in pregnancy? Anybody? Ultrasound and MRI are safe in pregnancy. They do not use X-rays. Ultrasound and MRI are safe in pregnancy. They do not use X-rays. Okay, everybody, now I can see I have a brilliant batch of brilliant students on the chat box. Please tell me, everybody. Let's see if you can answer. If you have a patient with ocular metallic foreign body, okay, ocular metallic foreign body, will you do MRI? Yes or no? Okay, tell me. If you have a patient with a foreign body in the eye, which could be a metal, MRI, yes or no? Anybody? This is last year's question of ionized set. Very, very important. Let's see how many of you can answer. Anybody? Anybody can answer my question, beta? Let me know in the chat box. Yes or no? The answer is MRI is contraindicated, because in the magnetic field, the metallic body will have more force on it. It will cause more damage. And I am telling you today that you are reading hi-fi stuff. The exams are asking these basic things. From these basics, I will gradually build it up for you. I will tell you the concepts. I will go step by step. Okay? Everybody clear? Okay. So what is the investigation of choice if you have a ocular foreign body? Anybody? What is the investigation of choice if you have a foreign body in the eye? The answer will be CT scan, not MRI, because MRI is contraindicated. And you might have seen this question also being asked in the NEET exam in the past. Investigation of choice for foreign body in the eye, CT scan. Are you clear? Okay. So we've just started the discussion with some warm-up questions. Okay. So people who have just joined, don't worry. People who have just joined, all I said so far was CT scan uses X-rays. Okay, clear? Should not be done in pregnant ladies. In pregnancy, you can do MRI and ultrasound, but MRI should not be done if you have a metallic foreign body in the eye. Intraocular foreign body, do a CT scan. Clear? Okay. Okay, first page, we just started. Okay, we just started. This is the first slide on the screen, everybody. Okay, this is the first slide on the screen for everybody. Okay, clear? Okay. Now second question is, okay, everybody, suppose I am doing my X-ray, X-ray beam is coming from my body and behind me I have a X-ray. So that means, everybody now tell me, routine X-rays are two-dimensional. What about CT scan? Okay, anybody? X-rays are two-dimensional. Tell me beta, what about CT scan? Mark this very important one-liner. Tell me now, CT scan is a two-dimensional investigation or three-dimensional? Anybody? Anybody? Tell me. Three-dimensional. CT scan is a three-dimensional investigation. So you will see these tiny little things we are able to find out just by understanding the diagram. CT scan is a machine where X-ray tubes are rotating around the patient to give a 3D perspective. Not only the length, breadth, but also the depth. That is the third dimension. Okay? Very good. Everybody clear? Okay. So once you are clear, I will now ask you the second concept. And don't worry, everybody is just warming up. I will go to deeper and deeper concepts with you. Whenever we do a X-ray of any patient, any one of you can tell me, on X-ray, we are able to see, okay, this is just the first few minutes of the lecture, Dr. Monu. Anybody now? Whenever we do X-ray of a patient, we are able to see black and white color. Okay. Whenever we do X-ray of a patient, we are able to see black and white color. Okay. Anybody tell me, on X-ray, if you see something white, how will you describe it? On the chat box, please let me know. On X-ray, if you see something white, you will call it opaque. Okay. On X-ray, if you see something white, you will say opaque. If you see something black, you will call it lucent. Okay. If I see something white on the X-ray, I will call it opaque. If I see black, I will say lucent. Okay. Everybody clear? Okay. Very good. Now tell me, on a CT scan, we are using computers. On a CT scan, we are using computers. On a computer screen, you have more shades of gray. You have black, you have white, but you also have other shades of gray. Okay. On a CT scan, you have more shades of gray available to you. The pun that you get in your mind is intended. Okay. Anybody now? Everybody now listen to me. Listen to me. I'm answering your question and I'm asking you to answer. Okay. Tell me. If I now tell you, as compared to X-ray, CT scan has a wider gray scale. Are you able to understand? Are you able to understand that on a X-ray you have a limited ability to see black and white? On a CT scan, because we have computer screen, we have a wider gray scale. Are you clear? Are you able to understand? Okay. Now, once you are able to follow my question, the second part is, let's see if you can answer. Everybody, please tell me. Now, there was a man called as Hounsfield. Okay, there was a man called as Hounsfield. After his name, we have a scale which is called as Hounsfield scale. Okay. Now, let's repeat and understand. Let us repeat and understand. See, everybody try to understand. If you have any tissue in our body will have different electron density. Okay. Every tissue in our body will have different electron density. As compared to that, So they will stop the X-rays at different level, which is called as attenuation. Okay, I'm again repeating. Every tissue in our body will have different electron density, hence it would stop the X-rays at different levels. Okay, everybody now tell me, everybody listen to me. If I'm doing X-ray of my hand, bone will stop the X-ray. Bone will stop the X-ray. So it will appear opaque. It will appear white. Are you clear, everybody? While air will not stop the X-ray at all, it will appear black. Clear, everybody? Okay? Everybody understands this? So now Hounsfield, what he did was, on the basis of tissue attenuation, he made a scale ranging from plus 1000 to minus 1000. In between we have 0. Okay? Everybody now, I am repeating for everybody. Now, I am saying everybody listen to me. Every tissue has different stopping power. That means whenever I am doing a X-ray, different tissues will have different electron density. Hence, they will stop at different levels. On the basis of attenuation, Hounsfield made a scale called as Hounsfield scale, ranging from minus 1000 to plus 1000. Okay? Everybody now answer the question. Everybody now answer the question. Hounsfield scale is based on, okay, one liner, anybody. Hounsfield scale is based on which tissue property? Anybody tell me? Hounsfield scale is based on which tissue property? Tell me, anybody? The answer is attenuation. Attenuation. And second question that has been answered wrongly by many people. Attenuation of the tissue is based on, anybody tell me, attenuation of the tissue is based on electron density. Attenuation of the tissue is based on electron density. Clear, everybody? Okay. Now try and understand. Hounsfield scale, at the number 0, we have kept water. So water has a Hounsfield unit, we will say HU of 0. Again, it's a classic one-liner, many times asked. On a Hounsfield scale, on a CT scan, water has a value of, anybody? Water has a value of 0. As compared to water, bone and calcium have more attenuation power. They will be at plus 1000. And air will be at minus 1000. Okay? Everybody follows? Very basic thing. But without basics, I cannot take you to the high level concepts. Okay? Everybody, I am repeating for you. Okay? I am repeating for everybody. Okay? On the basis of electron density of the tissue, different tissues have different attenuation. What is attenuation? Attenuation means how much X-ray a tissue can stop. Okay? On the basis of attenuation, Hounsfield devised a scale called as Hounsfield scale or Hounsfield units, which varies from minus 1000 to plus 1000. Minus 1000 is air, 0 is water, plus 1000 is bone and calcium. Okay? Clear, everybody? Now, I want you to answer, beta. Let's see how many of you are able to answer this. Plus 1000 on CT will appear white. Plus 1000 on CT will appear white. Minus 1000 will appear black. Everybody follows? So, bone on a CT will be white. Calcium will be white. Air will be black. Air will be black. Water will have a color in between black and white. This is what, when we will look at the images, we should be clear. Bone and calcium on CT will appear white. Air will appear black. Water will be in between white and black. Okay? Everybody clear? Okay. Now, let's see an answer, beta. What does HU mean? Farhan Raza is saying, what does HU mean? HU means Hounsfield units. Okay, Farhan, Hounsfield units. Clear? Okay. Everybody follows? Okay, now let's see an answer now. Everybody now, let's see an answer. See, as compared to water, our normal brain tissue has a Hounsfield value of 20 to 40. As compared to brain tissue, as compared to water, brain has a Hounsfield number 20 to 40. Hemorrhage 60 to 70. Hemorrhage 60 to 70. Okay, and fat tissue is at minus 100. Fat tissue is at minus 100. Everybody clear? Okay, so I am repeating once more. Okay, I'm repeating once more. Okay, let's see, everybody try to answer. So now try and imagine in your mind, whenever we will look at a CT scan, the bone will look the whitest, calcium will be white, okay, air will be black, water will be in between white and black. As compared to water, fat will be more black. As compared to water, brain will be more white. As compared to brain, hemorrhage will be more white. Clear? This is the first page. Clear, everybody? Clear? Okay, well done. Okay, well done. Let's do now. Now, my question to you is, I will now ask you to explore a why. Okay. Have you ever heard a term in your radiology department saying hyperdense, hypodense? Okay. So everybody now tell me, have you ever heard, okay, have you ever heard in your radiology department saying hyperdense, hypodense? Okay. Try and imagine and understand. As compared to brain, a hematoma or hemorrhage or a blood clot will be more white. Okay, as compared to brain, a blood clot or hematoma will be more white. So how will I describe it? I will say it is hyperdense. So whenever we are doing a CT, any disease which is more white than the organ that we are looking at, we will describe it as hyperdense. Hyperdense. Why it is happening, I will explain, give you the why here. Listen to me. In a blood clot, you have heme and you have globulin. You have hemoglobin. In blood clot, the RBCs come close to each other. Whenever the blood clots, the RBCs, they are tightly packed. They come close to each other. And globulin is a protein, so it will have electron cloud. You remember globulin is a protein. Protein will have a lot of electrons in it. So what happens is, in a blood clot, RBCs become tightly packed. And all the globulin will become tightly packed. Are you clear? And the electron density will cause it to become hyperdense. So I am trying to answer this question, and I am sure you should be able to answer. Okay. The question is, let's see, anybody? Acute brain hemorrhage on a CT scan appears. What is the answer? Hyperdense. Hyperdense. Clear? With time, the clot will liquefy. So with time, it will become hypodense. So, but once we are able to understand the concept, it will stay with us. Okay? It will stay with us. Okay? So we see some, fake profiles here and there, but listen to me. Everybody listen to me. Water on a Hounsfield scale has 0 Hounsfield units. Okay? You can make the app full screen by going like this and removing the chat. Go full screen, focus on the class. Okay, everybody. Go full screen, focus on the class. Water has Hounsfield number. Anybody? 0. Air, minus 1000. Fat, let me know, everybody in the chat box, minus 100. Brain, 20 to 40. Hemorrhage, 60 to 70. Bone and calcium, plus 1000. Bone and calcium, plus 1000. Okay. This is just a beginning, and then we will go through your workbook to see the clinical images, Dr. Pragya. But listen to the concept first. Because you have all heard of all this, brain hemorrhage is hyperdense. I am telling you why it is hyperdense. Because if it is a blood clot, RBCs will come close to each other. RBCs have hemoglobin. The globulin has electrons, so electron density increases and it becomes hyperdense. It is because of the tightly packed globulin. Okay, everybody clear? Okay. What is HU? HU is Hounsfield units. Okay, so all this is called as Hounsfield units. And even this has been asked as a question. HU stands for Hounsfield units. Okay, clear everybody? Okay, now once you're clear with all of this, okay, I will immediately take you to a image and we will try to look at the image together. Okay, everybody now look at the first image of the class. Okay, look at the first image of the class. Okay, now tell me, what part is this? This is brain. I want all of you to look at the bone. I want all of you to look at the bone. Look at the bone. What is the color of the bone? Tell me. White. That tells you that you're looking at a CT scan. On a CT scan, calcium bone will appear white. Everybody clear? Okay. Now. Okay. Now. Everybody listen to me. I will show it to you. Everything will be clear to you once you start listening to me. I will tell you, show it to you. Listen to me. Okay, listen to me. Everybody listen to me. Whenever we look at a CT image, very important basic point. We are looking at the patient from his foot end. Okay. You are standing on the foot end facing the patient. We are looking at the image from his foot end. This is the right side. This is the left side. This is the anterior. This is the posterior. Okay, this is the first image of the class. Okay, I am looking at the first image of the class. Okay, everybody now tell me anterior, posterior, right, left. Clear? So what happens is 90% of MBBS students, they don't do hi-fi things wrong. They make mistakes in small basics like this. Everybody now follow me. Everybody listen to me. Right, right, left, anterior, posterior. Okay, everybody listen to me. First image of the class. Whenever you are looking at a CT scan, top of the image is anterior, bottom is posterior, right, left will get inverted because you're looking at the image from the foot end. Right, left will get inverted as per your hand. Right will not be on the right side. It will be inverted. Okay, clear? Why this is happening? Because it is a protocol. This is how we align the images. It is the protocol. We are looking at the image from the foot end of the patient. Okay? Clear everybody? Okay. Now everybody now answer this question. Everybody answer this question first of all. Okay? I will give you small tips and gradually we will go up and go higher onto the images. Okay? First of all, I want you to look at this image. Okay. Suppose this is a 3D section of the brain. This is where your cerebellum is located. This is your temporal lobe, frontal lobe, orbit. Okay. Now imagine a section passing through this area. Okay. I want everybody just imagine a section passing through this area. It will pass through the cerebellum, temporal lobe, orbits. Okay. Clear? Okay. Now let's go back. Okay. Everybody let's go back. Page number, first image, first page of the class, first page. Okay. Now tell me everybody. I am now labeling it for you. I am putting here 1. And I am saying 1 is equal to. Anybody tell me what is the number 1 showing us? What structure do you think? All of you bright students, tell me what is the structure that you see on number 1? That is your orbits. Okay, that is your orbit. Very good. As soon as you say orbit, are you clear now that we will be looking at the inferior part of the brain because we are at the level of the orbit, because this is how the skull will be like this. So we are at the level of the orbit. Okay. So if we are at the level of the orbit, all you brilliant students can now tell me what will be the number 2 structure here. What will be the number 2 structure in the image? Okay, just now I taught you with an example of a 3D image. Are you clear now? At the level of orbit, when you come backwards, you can see the temporal lobe, and behind it you can see the cerebellum. Everybody clear? So the number 2 in the image will be, temporal lobe, and I can see most of you are rocking the show. Some of you are warming up still, okay? But I'm promising you I will work very, very hard with you. Don't worry. Okay, number 2 is temporal lobe. Okay, everybody now tell me, everybody focus on the class. Number 3. So to understand number 3, we need to understand this is your sphenoid bone. Okay. This white thing that you see here, everybody now notice this white thing that you see here is your sphenoid bone, the body of the sphenoid. Then you can see it has 2 wings. So that is your sphenoid bone. Everybody clear? Okay. So behind the sphenoid in the midline, you can see a bony fossa. It is bound by bone anteriorly, posteriorly both. Number 3 is a Turkish saddle shaped structure called as sella turcica. Number 3 is sella turcica. Everybody clear? Okay, beta. Everybody now. For the children who are finding it difficult, don't worry. Now please see, this is what you have learned in anatomy. I told you I will integrate everything. This is where I am showing you the sphenoid bone, and this is the area where we are looking at. This is where you have your sella turcica. Are you clear? Yes, very good. I can see most of you are getting the groove of the class. Okay. Now everybody, let's try to connect the dots. We need to learn how to integrate anatomy and radiology. That is my promise to you. What is the structure number 4? To understand the structure number 4, we need to know that this is your petrous temporal bone. Okay. This is where you have the middle petrous temporal bone dividing the middle cranial fossa from the posterior fossa is your petrous part of temporal bone. This is your petrous part of temporal bone. So behind it, when you see the number 4, you will see a fat rounded structure, a round fat thing. This round fat thing is nothing but your pons. Okay. This round fat thing is your pons. Number 4 is pons. And what about number 5? Number 5 structure that you see here in the posterior fossa is nothing but in the hind brain you have the part called as cerebellum. Number 5 is your cerebellum. Everybody clear? Are you able to get the labeling right? And this is how I want you to label in your image book. Okay. So for those of you who have the image book, do it like this. For others, you can revise it again and do it in the subsequently. It is very easy. Every time you will have to do it, it is very easy. Okay. I'm repeating. 1 is orbit. 2 is your temporal lobe. 3 is your sella turcica. 4 is pons. 5 is cerebellum. Okay. Everybody now, please look at the structure which is, I am putting an arrow here and putting a number 6. I am putting a number 6 here. Okay. Beta, tell me everybody. Pons and cerebellum, they will form your hind brain. Pons and cerebellum will form your hind brain. So in the hind brain, can you see number 6 is a CSF cavity. Number 6 is a CSF cavity. What cavity? Ventricle. What could be number 6 between pons and cerebellum? 4th ventricle. 4th ventricle. Okay. That is your 4th ventricle. Everybody understands? Okay. Now I will show you some tough question now. Everybody now, gear up, let me know. Let me know, beta. Number 7. Number 7. First image of the class. Everybody, first image of the class. Number 7. Number 7. Can you see number 7? Okay. So number 4 that you can see here is your pons. Number 5 is cerebellum. So this entire thing is your cerebellum, beta. This is your vermis. This is your hemisphere, cerebellum. Okay. So number 5 is your cerebellum. 6 is 4th ventricle. What is 7? Anybody? 7 is a CSF space bounded by cerebellum on one side, pons on the other side, and you can see it is a CSF filled space with petrous on the other side. This 7 is called as cerebellopontine angle, CP angle. Okay, everybody? So Dr. Jyoti, you got it wrong. Nidhi, no beta, no Nidhi Jaiswal. This is not lateral ventricle. This is your CP angle. And this is one of the reasons I decided to divide radiology into smaller parts, because it is very tough to take multiple subjects together. And I will do it in smaller fragments, and then I will take it all together with you in a face-to-face class. So because I want to make sure that you get 10 out of 10. Okay, everybody? Now, I will give you how the integrated MCQs will be found. Okay, beta? I am giving you MCQ. Everybody now tell me. Okay, I am giving you MCQ to solve. Okay, a patient with NF2 develops sensory neural deafness. You are given a CT scan. Okay, everybody listen to me. Okay, सुनो मेरे साथ, दोबारा सुनो, मैं सारा रिवाइज करूंगा, don't worry. Okay, it is the first image of the class. I am saying if a patient had neurofibromatosis type 2 and deafness, and you are looking at a CT scan, where will you look at? Okay, क्वेश्चन बताना है. पैथ भी इंटीग्रेटेड है, क्लिनिक्स भी इंटीग्रेटेड है, पैथोलॉजी भी ऑफ्था भी. एनीबडी नाउ टेल मी, पेशेंट हैज NF2. Okay, NF2, tell me beta, NF2. Okay, you will look at the CP angle because neurofibromatosis type 2 is associated with vestibular schwannoma. But where will you look at? Number will be 7. So your eye has to go to number 7. So after my class, you give USMLE, you give INI-CT, you give NEET PG, no problem. I will cover all the concepts. Okay. So this is a typical style of clinical vignette. They will make a question based on pathology and deafness ENT, but the answer will be in radiological anatomy. Clear? Very good. I can see most of you are able to answer. Yes, Ramesh, Kashma, Bansi, Pratul, Nikhil. Very good, beta. Now second question, everybody listen to me. I am going to give you now the next level medicine question. Okay. A chronic alcoholic has hyponatremia, which was rapidly corrected, now admitted to ICU. Okay, I am saying a chronic alcoholic had hyponatremia. Write it down. Clinical vignette I am trying to create. Chronic alcoholics are prone to electrolyte imbalances, so he has low sodium. Rapid correction was done. Now admitted to ICU. Where will you look in the radiological image? Okay, where will you look? We have to now look for central pontine myelinolysis. So the answer will be number 4. We have to look for central pontine myelinolysis. Clear, everybody? So where is pons? Pons is at number 4. Pons is at number 4. Clear, beta? I am again repeating for Geeta specifically. She is getting it wrong now. Bache, yaad kar lo Geeta. 1 is orbit, 2 is temporal lobe, 3 is sella, 4 is pons, 5 is cerebellum, 6 is fourth ventricle, 7th is CP angle. Okay? Everybody gets it? Okay. Now answer one more question. Last year in one of the NEET exams, they gave a question and they put an arrow like this and said identify the organ. So what is the organ here? Cerebellum. So my arrow is at cerebellum. Number 5, cerebellum. So the theme here is radiological anatomy, but I am trying to integrate it with the concepts. Okay. I am giving one more question to you. Okay, one more clinical question, but the answer is located in anatomy of the brain. A patient develops HSV1 encephalitis. A patient develops HSV1 encephalitis. Where will you look for the problem? Tell me beta. Patient को herpes simplex virus type 1 encephalitis है. आपको CT scan दिया गया. I am repeating in English. You are shown a CT scan of a patient with herpes simplex encephalitis. Where will you look for the problem? Where will you look for the problem? temporal lobe. Why? Because HSV type 1 has predication for the temporal lobe, or they might say for limbic system. Okay, so the answer is 2. Clear? So I hope you see the concept that I have tried to build up so far is, I am trying to tell you applied radiological anatomy. Applied radiological anatomy. Okay, clear? Brilliant. So it is so good to teach all of you brilliant students, and I totally love you all. And I will now tell you with the image. Listen to me everybody, look at the image and answer again. So at the lower part you have the temporal lobe and you have the cerebellum. Okay, at the lower part you have the temporal lobe and the cerebellum. But when you go up at the level above the orbit, you should see the frontal lobe, parietal lobe, occipital lobe. Okay, so above it, when we go above the level of orbit, you should be able to see the frontal lobes. Okay. Once you are all clear, it becomes so simple, because I know you are all so easy. Now some of you are saying, Madhuri Sharma is saying, why is the reason? Reason beta, temporal lobe नीचे होते हैं. अगर आपको याद हो, मैंने middle cranial fossa पे दिखाया ना आपको नीचे. Okay, Madhuri, clear. Now everybody, listen to me everybody and answer this beta. Identify the structure marked as 1. Identify the structure marked as 1. Front of the brain should be frontal lobe. Structure marked as 1 is frontal lobe. Okay, anybody now tell me? Number 2. Number 2 is your temporal lobe. Okay, so the key is, in the first image we only saw the temporal lobes and cerebellum, but as I go up, now I am able to see even the frontal lobe. As I go up, I am able to see the temporal lobe as well as the frontal lobe. Okay, can you see the difference here? Beta, I think one bacha is saying, what is the difference? Please see beta, please see. Yahan pe you could see the orbit. You can even see the frontal sinus in the cut section. You can see the sinus also is seen here. Can you see it here? Okay, but when I go up, we are going below upwards. So when I go up, you start seeing part of the frontal lobe, part of the temporal lobe. And number 3, if all of you will have patience, we will see number 3 is your, anybody? Pons. Number 4 is still your cerebellum. Okay. Thakkar Yashvi is saying, sir, why not parietal lobe? Very classic question. I will explain it to you. Don't worry. I will teach you parietal lobe also. Beta. I will not go home without teaching you everything. Okay, that's my promise. Okay, and you can already see that your problem is in basics. It is not in the hi-fi stuff. So that is why I will go step by step. But don't panic. I will teach you every disease possible for your exam. But first I will show you anatomy. Okay, 1 is your frontal lobe. 2 is your temporal lobe. 3 is pons, and 4 is still cerebellum. Okay, everybody clear? Everybody clear? Okay. Now see, Nidhi is saying, sir, why not midbrain? Beta, midbrain भी दिखाऊंगा, promise. और ऊपर आएंगे ना तो midbrain आएगा. Midbrain का shape अलग होगा. Okay, everybody listen to me. Okay, now we are at the lower part of the frontal lobes. और ऊपर जाएंगे ना बेटा और दिखेगा. फरहान रजा और ऊपर दिखेंगे, है ना? Patience. Everybody patience. Okay, now question number 1 coming your way. Everybody. Now suppose number 3 is pons. Anterior to the pons, you have a blood vessel sitting here. Anterior to the pons, you have a blood vessel sitting there which is supplying the pons. Anybody wants to tell me the name of the blood vessel? Anterior to the pons, you have a blood vessel supplying the pons which is called as the basilar artery. So suppose you forget everything in the exam, and in the exam they say pons is supplied by, the answer is basilar artery. At the level of medulla, you have the vertebral arteries which join at the level of pons to form the basilar artery, unpaired artery. Clear everybody? Okay. Anybody now? One more question coming your way. I know you are all smart children. Please tell me. which blood vessels will be here? Okay, I'm going a little back. There is a blood vessel which is on either side of sella turcica. There is a blood vessel which is on both sides of sella turcica and then reaches between the frontal and temporal lobe at this area. What could this be? This is your internal carotid artery. This is your internal carotid artery. Everybody gets it? Internal carotid artery. Okay. It is in the cavernous sinus, then it goes up like this. This is where you have your internal carotid artery on a CT scan. Clear, everybody? Okay, beta. Okay. I can see most of you, Satya, Aryan, Monisha, Harish, Soumyadeep, you are able to get it. Guess. Good. Now tell me, everybody now. I am going to make it tough for you now. Okay. Now what happens is, I want you to look at these CSF spaces. Okay, everybody patience. Okay, but I will show you middle cerebral artery also, don't worry. But I want you to look at these CSF spaces. The CSF space between pons and cerebellum, CSF space between pons and cerebellum is, anybody? Fourth ventricle. CSF space between pons and cerebellum is fourth ventricle. And what is the CSF space in the temporal lobe? What is the CSF space in the temporal lobe? That is the inferior horn of the lateral ventricle. That is the inferior horn of the lateral ventricle. Okay, I will explain to you, beta. I will explain to you. Now, because we are gradually coming to the concept, please see here. This is your anatomy diagram. Everybody, don't panic. Don't panic with anatomy. Don't worry, don't worry, don't worry. Listen to me. This is your body of lateral ventricle. This is the anterior horn, posterior horn, inferior horn. Clear? Everybody understands? So lateral ventricle has a body. It has a body. It has a anterior horn. It has a anterior horn in the frontal lobe, posterior horn in the occipital lobe, inferior horn in the temporal lobe. Okay. And if you now notice, this is where we had pons, cerebellum, medulla, and what is the ventricle that you see between pons and cerebellum? That was your fourth ventricle. Okay. Now tell me, this inferior horn of the lateral ventricle is first to dilate in hydrocephalus. If you have a patient with hydrocephalus, inferior horn of the lateral ventricle is first to dilate. Okay, I am repeating, everybody, don't panic. I am repeating, don't worry, listen to me now. I am again repeating, everybody, I am removing everything, don't worry. One is frontal lobe, it is the part of the frontal lobe. Two, temporal lobe. 3, pons. 4, cerebellum. Okay, 4 is cerebellum. Anterior to pons you have the basilar artery. Between frontal and temporal lobe you have the internal carotid artery. Internal carotid artery gives a branch. Internal carotid artery gives a branch which goes laterally towards the lateral sulcus, towards the lateral surface of the brain, which is called as middle cerebral artery. So this is the location of middle cerebral artery. I will apply it in diseases later on, but I hope you are clear. This is the location of middle cerebral artery, and the anterior cerebral artery is towards the midline. Anterior cerebral artery goes anteriorly towards the midline. Clear? Okay, everybody clear? Yes. Now let's see and answer a question. Okay, everybody, now are you ready for your question now? Are you ready for your question? Okay, I will make it slightly tough, but it is very important from your exam perspective. Let us look at the temporal lobe. This is the shape of your temporal lobe, beta. Okay, so this temporal lobe has a lateral part. It has a lateral part and a medial part. Temporal lobe has a medial part. This is your medial part. Okay, medial part is further divided into, okay, anterior part, medial most part, posterior part. Okay, everybody, it is slightly tough, but very important integrated MCQs coming your way. Okay. Identify the structure marked with number 5. What is number 5? Tell me. Number 5 is a part of the mesial temporal lobe. It is the part of the mesial temporal lobe anterior to the inferior horn of lateral ventricle. What could this be? Temporal lobe है, temporal lobe में अंदर की तरफ, आगे की तरफ. What could be number 5? What could be number 5? Number 5 is amygdala. So this is how you will identify it in the exam, amygdala, and this is where your fear is. Many times you say, sir, exam nahi hoga, nahi nikal paega, so that is fear. Fear is in amygdala, emotion, fear, amygdala. Okay. So how will you identify amygdala? So Ankita Sarkar is saying, what is the question related to inferior horn? Inferior horn is the first part of the ventricular system to dilate in patients with hydrocephalus. Okay, Ankita? Okay. What is number 6? Number 6 is the medial most part of the temporal lobe. Medial most part of the temporal lobe, which is called as the uncus. And number 7, look at number 7, posterior to the inferior horn. Number 7 is located posterior to the inferior horn. This is number 7, beta, this one. This area that you see here is called as, anybody? 7 is your hippocampus, where your memory is located. 7 is your hippocampus. Okay, so all the bachas now, try to understand how your exam will be formed. Okay, I am giving you a question. Okay, this is one of the questions that I was recently teaching, and one of my student got in his step 1 USMLE. They said, fear as a emotion, which part of the brain in the image shown to you is responsible for fear? Anybody? The answer will be 5, amygdala. 5, amygdala. Second question that I saw in NIMHANS, I saw it in INI-CET. The question is, patient with Alzheimer's dementia. Okay, patient with history of Alzheimer's dementia. Where will you look for the changes on a CT scan? If you have a patient with history suggestive of Alzheimer's dementia, they will say, lady has a mother who is forgetting where she keeps the key, where she keeps the any stuff, then she is unable to come back home, she is having cognitive decline. So where will you look for it? We will look for the changes in the hippocampal volume. Where is hippocampus? Number 7. Okay, are you clear now? So most children, they don't get hi-fi questions wrong. They get trapped because they don't know where is hippocampus, where is brain, where is frontal lobe, where is temporal lobe. They are getting stuck there. And I am trying to go from the very basic and going up to the anatomy. Then I will show you pathology also. My promise. Okay, my promise that I am here to make your job much easier, and I'll work very hard. Okay, clear everybody? Okay. Second question, beta. Everybody now answer. I can see. Which part of the brain herniates in transtentorial herniation? I will explain this concept in a little while, but let's see if you can understand and answer. Which part of the brain will herniate if you have transtentorial? Tentorium is a dural fold. If the brain herniates below the tentorium, which part will herniate? The part which is most medial sitting here. What is this most medial part here? Tell me. That is your uncus, number 6. That is your uncus, number 6. So we need to know the anatomy to get to the clinical questions. But if we don't know the anatomy, then the clinical questions will go wrong. Okay. Many students will say, sir, teach us clinical thing. I will first teach you basic, then I will take you to clinical thing. Okay. Now, please see this space here. Everybody, please see this space here with me. See this CSF space. Everybody now, see the CSF space here. Okay. This CSF space is bounded in front by frontal lobe, On the side you have the temporal lobe, behind you have pons. Okay. What is this CSF space? I am again repeating, Chaitanya. And Astha, don't worry, I will show you transtentorial hernia. I will talk about it. But first you answer my question, beta. What is this CSF space labeled as number 8? Labeled as number 8, which is bound by frontal lobe, temporal lobe and pons. This is called as suprasellar cistern. This is called as suprasellar cistern. Are you clear, everybody? Because this is a CSF space located above sella. See the previous section? This is where you had sella. In this particular section, you have CSF space above the sella. Okay? Okay, everybody now. Okay, I will explain to you, but I want your patience. I want your patience. Tell me. In the sella turcica, you have the pituitary gland. So what will be present in the suprasellar area? Rohan, Sanjay Patil, beta. Rohan, beta, this is not third ventricle. Third ventricle is in the diencephalon. It will be seen when we see thalamus. Not here. This is, we saw it is bounded by frontal lobe, temporal lobe and pons. This is cistern, suprasellar cistern. In the sella you have pituitary. So what will you have above the sella? Anybody? Tell me, what will you have above the sella? You will have infundibulum or stalk. Okay, so in sella you have pituitary. In the suprasellar cistern you have the pituitary stalk or the infundibulum, which will connect it to the hypothalamus and the diencephalon. We will see it later on. But my question to you is this. My question is this. Anybody now? Tell me now. Suppose in the infundibulum, by mistake, you have a Rathke's pouch remnant. Suppose you have by mistake some remnant tissue left in the infundibulum of Rathke's pouch and it becomes a tumor. Okay. Suppose you see, I am trying to label everything now. Everybody see with me. Suppose you have a patient like you saw in one of the NEET PG exams, a tumor sitting here. Okay. Everybody now. Patience, 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 patience. Tell me, bache, where is the tumor located? Where is the tumor located? Suprasellar cistern. So that means it must be arising from the infundibulum. And if you have a tumor arising from the pharyngeal component of pituitary, which is the Rathke's pouch remnant, what is that called as? That is called as craniopharyngioma. And this is one of the visual questions that was asked in NEET exam. But if you don't know anatomy, then you will think, I don't know what it is. But if you know this is suprasellar area, you can pick it up, that suprasellar tumor in a child, craniopharyngioma. And don't worry, I will show you the brain tumor separately also. But right now my goal is to make sure that you understand the anatomy. Okay, this is where you have the suprasellar cistern. Okay, Prachi, are you clear? Okay, Prachi, for you especially I am repeating, beta. 1 is your frontal lobe, 2 is temporal lobe, 3 is pons, 4 is cerebellum, 5 is suprasellar cistern, 6 is amygdala, 7 is uncus, 8 is hippocampus. Okay. So I'm again repeating. Okay, everybody. Okay. So as you go up, one bacha has asked this question, very important question. When will we see the lateral ventricle? Or upar jayenge na to lateral ventricle dikhenge. When we go further up, we will see the frontal horn and the posterior horn. Abhi nahi dikhenge. Okay, because it is like this. Inferior horn is lower down. So when you see inferior horn, you will not see the anterior horns. Okay, everybody clear? Okay. Now for Rija, I am repeating. In the suprasellar cistern, you have the infundibular stalk. If you have a Rathke's pouch remnant in the infundibulum and it becomes a neoplasm, that is called as craniopharyngioma. Craniopharyngioma is a tumor arising from Rathke's pouch remnant. Everybody clear? Okay? Okay. Everybody clear now. So don't worry, I will repeat this point again when I show you the brain tumors, but right now my goal is to make sure that you are clear on the anatomy part. Everybody clear with this much anatomy? Okay, everybody clear? Okay, so we will go up. So everybody try to understand, I am taking sections of the brain from the level of orbit, then I went up, now I am going further up. Okay. So when I do a further, we go on the section, you can see in the front of the brain, we can see in the front of the brain, what is one? Anybody? What is one? Patience. Okay, slow. We have no hurry. That is why I have divided into smaller sections, because radiology cannot be hurried. It is very difficult. But once you understand, all 10 out of 10. Okay. What is one? Front of the brain. Front of the brain. Frontal lobe. Front of the brain is frontal lobe. Okay. Clear? Very good. Now I want you to see this area, beta. 2. Okay, don't worry. The numbers might be a little interchanged, but the concept is clear. I will repeat it again also. What is number 2? Okay, what is number 2? Temporal lobe. Okay. 1 is frontal lobe, 2 is your temporal lobe. Okay, everybody? Clear? Okay. Now you have to tell me what is this structure. Okay, beta? This is very important. Okay, everybody now look at it. Okay, everybody look at it. Between your frontal lobe and your temporal lobe, on the lateral surface of the brain, can you see a large sulcus marked by my red arrow? Yes, can you see? Between the frontal lobe and the temporal lobe, there is a large sulcus on the lateral surface of the brain, which is marked by the red arrow, which is nothing but your lateral sulcus, which is also called as the Sylvian fissure. Okay, which is also called as the Sylvian fissure. Now I can see kuch bacche jo they are also still now saying this is parietal lobe. No, this is not parietal. You will see parietal lobe above the level of Sylvian fissure. जब तक Sylvian fissure दिख रहा है वो temporal lobe है. Okay, try and understand now. One is your frontal lobe. In between you can see the Sylvian fissure, and behind it you can see the temporal lobe. Everybody clear? Okay, beta. Okay. Now see, your middle cerebral artery. Remember, middle cerebral artery arises from the internal carotid artery, goes laterally towards the lateral sulcus. Okay, so middle cerebral artery will go into the lateral sulcus. I will now give you a tough question to solve. I will give you a tough question to solve, beta. Let's see if you can answer. Can you see this part of the brain here? Can you see deep to the lips of the Sylvian fissure, you have some brain cortex. Can you see here? Brain cortex hidden by the Sylvian fissure. Brain cortex in the depth of the Sylvian fissure. What could this be? What is this area? Anybody? Brain cortex hidden by the Sylvian fissure, I am labeling it as 3, is called as your insula or the insular cortex. I am sure when you were reading in anatomy, they told you that if you put your fingers in the Sylvian fissure, open up the lips of the Sylvian fissure, you see the insula hidden below it. Because the Sylvian fissure, it overgrows and covers it. So number 3 is your insula. Number 4. Now at the number 4, you can start to see a little bit of the occipital lobe. But the important thing is, this area is still your cerebellum. Okay, I am again zooming in for you. Okay, I am zooming in for you. Are you able to see this? Okay, are you able to see this? So this is your cerebellum. Okay, cerebellum. Cerebellum has this foliar architecture, so it is easily identifiable. This is foliar architecture. While in the cerebrum you have gyri and sulci. In cerebrum you have gyri sulci like this. Okay, but in cerebellum you have foliaceous. This is cerebellum. Okay, so I'm putting a number 5 here so that everybody is clear. Okay, I'm repeating for vigil and some bachas who could not see, I'm repeating. Beta, sabse aage, one is frontal lobe, okay? One is your frontal lobe. Two is your temporal lobe. Between 1 and 2, you can see a large sulcus which is called as the lateral sulcus or the Sylvian fissure. Okay. 3 is the part of the brain cortex which is hidden deep to the Sylvian fissure, which is called as insula. 4 is occipital lobe and 5 is your cerebellum. Okay. Are you clear beta? Okay. Anmol beta, सोचो ये जो एरिया, ये जो हम फिशर देख रहे हैं, ये सिल्वियन फिशर है, उसके जो ब्रेन का कॉर्टेक्स उसके नीचे दिख रहा है, वो इंसुला है. आप समझ पा रहे हैं बेटा अनमोल? Okay. Okay. Now some bachas are saying, how do we know that this is cerebellum and this is not? Let's try to see it closely now. Can you see wherever I am saying cerebellum, it has this foliar architecture. Can you see the architecture is like this, like foliar, line. This is how it is. While in the cerebrum, you will always have gyri sulci. I will show you in the next cut. Okay. I will show you in the next cut. Okay. Everybody now, just for a moment, give me patience and listen to my point here. Because this is the question that one bacha had already asked. I think Nidhi had asked. Bacha dekho, can you see this area? What is this? Is this fat and rounded? No, this is more like a heart-shaped structure. Above the level of pons, part of the structure which we see above the level of pons, which is shaped like a heart like this, has been asked in your NEET PG exam. What could this be? This area which I am labeling as number 6, is your midbrain, mesencephalon, midbrain. Clear beta? Are you able to identify midbrain? Confident? Okay. Now see with me beta. See with me. In one of the NEET PG exam, they put an arrow here. Can you see there is a line? Can you see here where I have put this arrow here? Can you see there is a white line dividing the two lobes of the brain, two hemispheres of the brain? What is this? This is a dural fold. This dural fold is called as falx cerebri. This dural fold is called as falx cerebri. Clear? Everybody understands? Okay. So Anmol, you have asked a question regarding insula. I will show it to you in the next section again. Just have patience, beta. Hai na? Just have patience. Okay. Everybody now listen to me. Falx is a dural fold that we saw here. I will now take you slightly more deeper into it. If you look at the midbrain has a shape like this. Okay. Midbrain has a shape like this. It has the crus cerebri, which can be called as the cerebral peduncles. Okay. And you can see here behind you have the tectum, where you have the superior and the inferior colliculi. Remember, anteriorly in the midbrain, listen to me here, this is your crus cerebri, and posteriorly you can see the colliculi. I will make it for you. Don't worry, anybody, don't panic. These are your colliculi, superior colliculi, and these are your crus cerebri. These are your crus cerebri. Okay. Are you clear, beta? I am again repeating the midbrain again. Raj and everybody, I am repeating the midbrain again. Midbrain has anteriorly two peduncles, the crus cerebri, where you have the pyramidal tract, and posteriorly you have the colliculi, which is called as the tectum. Okay. Just give me 1 second. Mandeep and all, don't worry. Just see with me, beta. एक चीज देख के बताना बस. ये मैं दोबारा बता रहा हूं. These are your cerebral peduncles. These are your colliculi. Okay, beta. Now please look at this. This is your optic tract. Now try and imagine. Close your eyes. Imagine. We saw the sella. In the sella you have pituitary. Supracellar you have the infundibulum. Above this you will have the optic tract, optic chiasm, remember? So this is optic tract. And between the optic tract, before you type anything, between the optic tract and the cerebral peduncles, you have a CSF space which is called as the interpeduncular fossa. Interpeduncular fossa. Okay. Now, Thakkar and Henry Patel are saying, how do we know the colliculi level? So we are going from below upwards. So we are right now at the level of the inferior colliculus. In the next cut, when you see the colliculi, I will tell you that will be superior colliculus. We are coming below upwards. Okay, beta. So the white shaded area that you see here is your interpeduncular fossa. Okay, everybody, try to understand. So interpeduncular fossa is between the crus cerebri and the optic chiasm. This is where you have the interpeduncular fossa. Now for those of you who have forgotten the interpeduncular fossa, let me show you interpeduncular fossa from your anatomy class. Remember in the anatomy they made you see this zone. Remember they made you see this area where you have the mammillary bodies, you can see the optic chiasm, the optic tracts, and here you have the crus cerebri. Remember interpeduncular fossa where you have the oculomotor nerve, also you can see the mammillary body sitting here. This is what you were learning in the anatomy. But the problem is when you learn in anatomy, when you come to see in the clinics, sometimes you are not able to diagnose because you have not correlated the two things. And that is what I am trying to do. Okay, everybody now see with me, beta. I am trying to make sure that you get the concept and you should not be able to forget. Okay, now tell me now. Number 6 is your midbrain. Everybody now clear? And number 7 is the CSF space anterior to the midbrain. Between the midbrain and the optic tract is called as the interpeduncular fossa, where you have the mammillary body, where you have the oculomotor nerve. Okay? Clear? Now one bacha is saying, why is the falx cerebri appearing a little white? Because you can have physiological calcification in the dura mater. With age and with time, sometimes you will see some calcium in the dura mater, that is normal. Clear? Okay? Now, my question to all of you is this. Okay? Do you remember in front of pons, we saw an artery called as the basilar artery? Remember? In anterior to the pons, we saw the basilar artery. So basilar artery will climb up along the pons. At the level of interpeduncular fossa, it will bifurcate into two branches. It will bifurcate into two branches. These two branches will be the terminal branches. I am again repeating, beta. Abhishek, I am again repeating. Okay. These are the inferior colliculi. Yes, Aksa Nakab, inferior colliculi. Okay. Now tell me, bache. At the level of the interpeduncular fossa, basilar artery will divide into terminal branches which are called as the posterior cerebral artery. Okay. Posterior cerebral artery. Now, let us do a side question. Okay. At the level of medulla, we are thinking that there will be vertebral arteries. At the level of pons, you have the basilar artery. At the level of midbrain, so midbrain is supplied by PCA. At the level of midbrain, you will have posterior cerebral artery. Clear? Okay. For those of you who are finding it difficult to understand, I will make sure that we form a concept. Listen to me and try to understand. Bache dekho. Because otherwise you will keep getting stuck. Suppose this is your dura mater, beta. Suppose this is your dura. Dura is the fibrous covering of the brain. Suppose this is your falx cerebri. So what would this be? This will be the tent. Tentorium. Just like a tent. It is like a tent. So we'll say tentorium. Okay. Now what is happening in the brain is, suppose this is where you have your frontal lobe, this is where you have the temporal lobe, okay, and the medialmost part of the temporal lobe was uncus, okay. This is where you have the, try to understand, I will try to make a diagram. You have the crus cerebri, pons, medulla, spinal cord. Okay, I am repeating PC also, Shalini Pradhan, don't worry, beta. I am trying to repeat it with a diagram. Okay. So through the tentorium, at the level of tentorial hiatus, you have the crus cerebri, then you have the pons, then you have the medulla. Okay, pons, medulla. Okay. Now try and imagine for a moment, it will take 1 second of your time. Remember, around the crus cerebri, which blood vessel was there? Between the crus and the uncus, you have the posterior cerebral artery. Now imagine now, it will take one moment of imagination. Okay, Isha and Shalini, I will repeat. Okay, suno mere saath ek baar. Suppose karo, you have a hemorrhage here. Suppose you have a hemorrhage in the, I will show you maybe extradural hemorrhage sitting here. What will happen? It will occupy some space. If it will occupy some space, what will happen? Brain will be pushed down, but dura is rigid. It will not be pushed down. So brain will herniate through it. So what will happen is, your uncus will herniate like this. Okay. So what will happen? Okay. So try to understand, beta. Anmol, tell me now. If the uncus herniates, if there is uncal herniation, which blood vessel will get compressed? Anybody now tell me. If the uncus herniates, which blood vessel will get compressed? Which blood vessel? Which blood vessel? Posterior cerebral artery. Posterior cerebral artery will get compressed because PCA. Just now I told you, beta, all the Isha and everybody who was getting confused. At the level of midbrain, basilar artery terminates into the terminal branches called as PCA. Midbrain will be supplied by PCA. Okay, beta. Now tell me. Anybody now tell me? Try to tell me. I will try to make it slightly tough. If you are able to follow, great. If you are not able to follow, I will rewind. Don't worry. Okay. Now tell me. When the uncus herniates, it will push the midbrain. It will push the midbrain to the other side. So this is the question that if anybody answers, I will send you my book. If you can answer, very, very important. When the uncus herniates, it pushes the midbrain, it pushes the crus cerebri to the other side. Okay. Okay. Now try to follow it. But it is tough. Okay. It is tough, but very important. Okay. Let's see how many of you can name what I am trying to tell. When the uncus herniates, okay, it pushes the midbrain, it pushes the crus cerebri to the other side. Okay. Now when the midbrain is pushed to the other side, the crus cerebri gets compressed against the tentorium. The crus cerebri, they get compressed against the tentorium. So can you see a notch is developing on the contralateral side? This is called as the Carnohan notch. Carnohan notch phenomenon. Okay, can you see? Now you can see that sir was telling only basic things. Suddenly he has gone up to the concept of Carnohan's notch. Now tell me, you have brain hemorrhage on this side, but the Carnohan's notch is happening on the other side. Can you see it here? Brain hemorrhage pushing the uncus, Uncus is pushing the midbrain against the tentorium, and you develop the Carnohan's notch on the opposite side. But the brain, the motor area, the motor track in the peduncle will get decussated at the lower level. So this part is going to control this area. So you will develop ipsilateral weakness. Ipsilateral to the brain hemorrhage. So that is why it is called as a false localizing sign. Have you ever heard of this or not? Okay, if you have a uncal herniation leading to Carnohan notch phenomena, it is a false localizing sign. क्योंकि hemorrhage इस तरफ है. Normally इधर बीमारी होगी तो दूसरी तरफ पे weakness आनी चाहिए. Carnohan's notch में you develop weakness ipsilateral to the side of hematoma because when uncus herniates, it pushes the midbrain, it pushes the crus cerebri against the tentorium and causes the Carnohan-Waltman or Carnohan notch phenomenon. Okay, I can already see a lot of requests for repeating. But are you now clear that radiology is not a simple subject? Why it is not simple? Why toppers opt for radiology? Because it is all about integrating anatomy, clinics, radiology and all radiation and pathology, everything together. Please see बच्चे मेरे साथ देखो. I will just for the sake of easy, for the Abhinav Mehta and everybody, for the sake of easiness, I will repeat in Hindi and English both, है ना? एक बार listen to me. देखो, जब अंकस herniate कर रहा है, तो अंकस टेंटोरियम के नीचे आया, क्रस सेरेब्राई के ऊपर दबाव पड़ा, ओके, क्रस सेरेब्राई पुश हो गया, and the opposite crus cerebri, opposite side वाला जो क्रस है, it gets compressed against the tentorium, and that is where you have the notch. Now this part is going to control the other side. So that is why you develop weakness ipsilateral to the side of hematoma. I am again repeating in English. Srinath, don't worry. I am repeating in English also. See, if you have a supratentorial hematoma, it can cause uncus to herniate below the tentorium. When the uncus herniates, it compresses the PCA, which I will just cover for you. It compresses the midbrain, and it causes Carnohan's notch on the opposite cerebral peduncle. And because the opposite cerebral peduncle is controlling the side, same side as the hematoma, you will develop ipsilateral weakness. Okay, read it again. Okay, read it again, beta. Read it again. Okay, now this is how it happens. Okay, now my question to you is, if you have PCA compression, if your posterior cerebral artery is compressed, what will you develop? You will develop cortical blindness. But the key question here is, which will be asked in your AIIMS exam, macular area is spared. Macular area is spared. Can you tell me why? Okay. In uncal herniation, because of PCA compression, you will develop cortical blindness, but the macular vision is spared. Can you tell me why? Can you tell me why macula is spared? Why macular vision is spared? Because macular area in the brain is supplied both by MCA and PCA. Are you clear? Because macular area has dual supply. It is supplied both by middle cerebral artery and posterior cerebral artery. So only PCA compression and macular vision will be spared. Clear, everybody? Yes, I can see most of you are able to answer the question. Clear? So you can see now that I am trying to build building blocks, taking you to the conceptual level. One more concept coming your way. If you allow me, okay, patience, it is tough, okay, it is tough, but if you understand, you will get extra marks. Okay, listen to me, everybody. So if you look at the anatomy of your brain, this is where you have the basilar artery, these are your vertebral arteries, and this is where you have the PCA. Okay. Now, anybody now, listen to me. It is tough question, listen to me. When the uncus herniates below the level of midbrain, it reaches till the pons. There are some blood vessels sitting here. So remember, from the basilar artery, you have pontine branches supplying the pons. So when the uncus herniates, it can tear these pontine branches. That means the uncus has herniated so much that it is causing a pons hemorrhage. Any one of you can answer. In severe cases of uncal herniation, you can have pontine hemorrhage. What is that called as? Anybody? What is that called as? Anybody? That is called as Durette hemorrhage. Described by Dr. Durette. Durette hemorrhage, and which has poor prognosis. So in patients with uncal herniation, if you see pontine hemorrhage, it will lead to, it tells you that it has poor prognosis. Are you able to understand the anatomy or not, beta? Dekho, socho ek baar. Dekho, what did I do? I told you this is where you have the uncus. If the uncus herniates, first it will compress the area of the midbrain, the posterior cerebral artery, or niche jayega, so it will also tear the pontine branches of the basilar artery, causing a pontine hemorrhage. So if in a patient with extradural hematoma, they show you pontine hemorrhage, poor prognosis, because it is telling you that severe uncal herniation ho chuka hai, this is Durette hemorrhage. Clear? So the goal of my class is not to tell you one thing, it is to show you how to integrate. Okay, my goal is to show you how to integrate. I will repeat 110 times, beta, don't worry. Okay, I will repeat 110 times, just keep listening to me, you will never get it wrong. Okay, I am now repeating with my numbers again. Frontal lobe, Sylvian fissure, temporal lobe, uncus, midbrain, cerebellum, interpeduncular fossa. Are you clear now? Are you able to do it, beta? Are you able to do it? Okay. So Nidhi is saying कि sir macular vision क्यों spare हुआ? बेटा देखो, uncal herniation में Nidhi, which vessel will be compressed? Posterior cerebral artery. But macular area, the area of the brain controlling the macular vision, has dual supply. It is supplied both by middle cerebral artery and posterior cerebral artery. So if only the PCA is compressed, macular vision will be spared. Clear? Okay, beta. Chalo, let's go up now. Let's go further up. Okay. I want all of you to give me patience, because if you give me patience, I will give you multiple MCQs in your exam. Okay. Listen to me. Frontal lobe, temporal lobe, occipital lobe. Can you now see? Everybody focus on your screen right now. Make it full screen. Listen to me. देखो, दिख रहा है ये area? This is still a part of cerebellum, because you can still see the foliar architecture. Otherwise, it is all about gyri sulci, so that is occipital lobe. This small part is the cerebellum left. And you might be asking why. Beta socho ek baar. If you remember, cerebellum has a shape like this. So when I am taking cross sections, first I could see it in the entire circumference. Now only the topmost part is visible. Okay. Now, Vaishnavi, I am repeating for you, Durate hemorrhage. Suppose the uncus herniates even further below the midbrain, it reaches to the pons. Then what will happen? Some vessels will get ruptured and you will see pontine hemorrhage. If in a patient with extradural hematoma, they show you pontine hemorrhage, poor prognosis. That means uncal herniation is so much happened that even pontine vessels have ruptured. Clear? That is Durate hemorrhage. Okay, everybody now, listen to me. Everybody listen to me. Listen to me. My request again, listen to me बच्चे. देखो, ये बताओ बेटा. What is this large fissure between frontal and temporal lobe? What is this large fissure between frontal and temporal lobe? Anybody can answer. That is your Sylvian fissure. That is your Sylvian fissure. And you can see here, what is this area? Insula. This is your insula. Are you able to understand? The bacha who was not able to follow insula. This is insula beta. Ye insula hai. Insula is the part of the cortex which is hidden deep to the Sylvian fissure. Ye Sylvian fissure hai. Jo CSF se bhara hua area dikh raha hai na, ye Sylvian fissure hai. And below it, the part that I have shaded is your insula. That is your insular cortex. Yaad aaya? Insula supplied by the middle cerebral artery located deep to the Sylvian fissure. Okay, now I want your patience. It is very difficult. Neuroanatomy is not simple. And if you go home and you realize I have not taught you radiology so far, I have been going for neuroanatomy first. Okay, I am telling you the CT anatomy first. Okay, I can directly go to disease, but I don't want to. So have patience. Have patience. Listen to me, beta. Listen to me. Okay, lateral ventricle, lateral ventricle. Now one bacha was asking, na, what part of lateral ventricle will you see in the frontal lobe? Anterior horns. These are the anterior horn of the lateral ventricle. This is your third ventricle. Okay. Clear? L is the lateral ventricle, and then we can see the third ventricle here. Now some of you were saying, sir, midbrain kyun nahi hai? I will show you midbrain beta. This is where your midbrain is. And can you see in the midbrain you can still see some colliculi. अब बच्चे देखो, मैं कोशिश, व्हाइट लाइन जो है ना वो टेंटोरियम है, वो टेंटोरियम के एजेस है. ओके, आई एम अगेन सेइंग बेटा, ध्यान से सुनो मेरे साथ बेटा. देखो, ये मिड ब्रेन में पहले वाले में आई शोड यू इंफीरियर कॉलिकुलाई. एज आई गो अप यू हैव दी सुपीरियर कॉलिकुलाई. ओके, नाउ टेल मी, everybody now tell me, in the midbrain, can you see this CSF filled duct? If this is your midbrain, can you see there is a CSF filled duct in the midbrain? CSF को बोल देते हैं हम aqua. aqueduct of Sylvius. Aqueduct of Sylvius. I will just, take a moment and just revise for you, because I know that, the problem is not in radiology. The problem is in your anatomy understanding. That is what I'm trying to fix. Okay. Do you see between the third ventricle and the fourth ventricle, through the midbrain, a thin duct is passing? This one is your aqueduct of Sylvius. So remember, अब याद करके बताना बच्चे, सोचो. Okay, Manoj Kumar is saying, so fourth ventricle कहाँ गया? देखो बेटा, fourth ventricle is the cavity of the hindbrain. Fourth ventricle is between pons medulla and cerebellum. But when you reach to the level of midbrain, then you don't have fourth ventricle. ना बेटा देखो, यहाँ पे कट लोगे, यहाँ पे section होगा, मनोज देखो, तो you will see fourth ventricle. But if I take a section here, you will see aqueduct. You understand this or not? And most people struggle in radiology because they do not know anatomy, and that is what I'm trying to fix. After my class, 10 out of 10. Okay, after my class, every question you should be able to do. I will spend a lot of time with you, don't worry. Okay, but this is where you have the aqueduct of Sylvius. So what I'm trying to say is that in the mesencephalon, in the midbrain, you have a thin duct called as aqueduct. Okay. Now try to understand. From the midbrain, you have the cerebral peduncles which connect your mesencephalon to your diencephalon. This is where you have the part of the inferior part of the diencephalon, which is where you have the hypothalamus. Okay, this area is your hypothalamus. Okay, try to understand. So we are going from below upwards. So we can now start to see a little bit of the diencephalon, which is the hypothalamus, and in between you have the third ventricle. Slit like CSF space, third ventricle. Okay. And okay, just give me 1 second here. Just give me 1 second, because I know the struggle is in your, because you have to try to appreciate that this is, I am trying my best to, so that we understand radiology, not rote learn. Okay. Now tell me bachas, everybody, suppose this is your hippocampus. From the hippocampus, you have this, a connection between the hippocampus and your mammillary bodies. From the hippocampus, you have the fimbriae, then the crura, then forming the body, then forming the anterior pillars of the fornix. So this is how your fornix is. Fornix is a connection between, it starts at the hippocampus, then you have the crura of the fornix, then body, then the anterior pillars. So what happens on a CT scan, listen to me, what happens on a CT scan, when you see the lateral and the third ventricle, are you able to see two pillars here? Okay, I'm removing everything else so that it becomes neat and clean. Are you able to see two pillars here? Okay. So, Bacha, I think Payal is having some network issue, but that is on your side, on your phone. So don't worry, I will upload the recorded class also, beta. Don't worry. But please tell me here, can you see these green marked areas, beta? Everybody now. And do you realize this has been asked in the NEET PG exam on a CT scan? What are these? These are two anterior pillars of fornix. Are you clear, beta? Are you clear? So L, Bhargavi, L was the lateral ventricle, 3 is the third ventricle. So anterior to the third ventricle, between them you can see two pillars. That is where you see on a CT scan the anterior pillars of fornix. Clear? Are you able to understand now? So I am again repeating. Because somebody has to work hard. Somebody has to work hard, because human body is complicated. God made it difficult. But you are doctors. You have taken on the challenge to understand it. Now see, between the hippocampus and the mammillary bodies, you have fornix. So this is how the fornix is. Fornix is like an arch. Fimbriae, crura, body, anterior pillars of fornix. So what we saw here, what we saw in this particular image, okay, I'm zooming it better, don't worry, I will zoom it also, okay. Can you see here, there are two pillars visible, okay, everybody now try to see, I will remove myself also so that you can see it clearly better. Can you see here? These are the anterior pillars of fornix. Okay. Shubhangi is saying, what is fornix? Fornix is a connection between your mammillary bodies and hippocampus. It is anatomically present. It was not invented radiologically. It is present anatomically. Now see beta, can you see this white line between the two cerebral hemispheres? That is your falx cerebri. That is your falx cerebri. Okay. So Soumya is saying, sir, hippocampus kahan gaya? Hippocampus was at the level of temporal lobe बेटा, इस लेवल पे नहीं दिखेगा हिपोकैम्पस, यहां करेंगे गलत हो जाएगा. हिपोकैम्पस was seen at the level of temporal lobes. यहां पे तो हाइपोथैलेमस आएगा, हाइपोथैलेमस, नॉट दी हिपोकैम्पस. हिपोकैम्पस टेम्पोरल लोब में मीडियली पोस्टीरियरली दिखेगा. ओके. सियानी चक्रवर्ती सिंह, वेयर इज हिपोकैम्पस अगेन? अब बच्ची अब सोच के अगर क्लास में नहीं आती आज तो क्या होता? दैट्स वेरी इट इज इंपॉर्टेंट कि व्हाट इज हैपनिंग इज ऑल ऑफ अस आर अज्यूमिंग वी नीड टू नो लॉट ऑफ थिंग्स, बट वी नीड टू नो व्हाट वी नो. हिपोकैम्पस, टेम्पोरल लोब, फ्रंटल लोब, बड़ी बड़ी बातें तो आई नहीं अभी तक, है ना? सो दिस इज वेयर यू हैव द हिपोकैम्पस. आर यू एबल टू अप्रिशिएट नाउ? ओके, क्लियर? ओके. नाउ सो ओनली ए प्लेस वेयर वी सी फॉर्निक्स ऑन अ सीटी इज दिस एरिया. सीटी पे फॉर्निक्स यहीं दिखता है, बस सिर्फ ये एंटीरियर कॉलम दिख रहे होते हैं. क्लियर बेटा? एंड दिस इज व्हाट दे आस्क्ड इन द एग्जाम. ओके, क्लियर? Okay, now one more question beta. I will show you one more question. I will show you fornix body also when I show you MRI. When you go further up, this is the most important section. I want full concentration for all of you. You can see the falx cerebri, anterior horn of the lateral ventricle, posterior horn of the lateral ventricle, third ventricle. Okay. Are you clear beta? Lateral ventricle, third ventricle. Okay. My questions to you are these. One बच्चा is saying, sir, mammillary body कहाँ है? Mammillary body याद है? Interpeduncular fossa में दिखाई थी मैंने. So mammillary body is seen in interpeduncular fossa. याद है? Mid brain के आगे. That is where you see it. Clear? Fornix connects the hippocampus to the mammillary body. Now everybody now tell me now. Now do you realize again, my question to you is, the problem is never in the hi-fi things. Although the children want to believe that, you know, if I can collect Harrison, I can collect thousands and hours of downloads in my phone, it will not work. It is always about live interaction where I am talking, you are listening, writing it down. Okay? Listen to me, everybody. Tell me बेटा, मेरे साथ बताओ, ये क्या चीज है? अभी बीमारी पे दिखाऊंगा ना बेटा, लेफ्ट में व्हाइट दिखाऊंगा जी, डोंट वरी. नाउ टेल मी, एनीबॉडी, व्हाट इज दिस येलो थिंग? So on the either side of third ventricle is the cavity of the diencephalon. Diencephalon is where you form the thalamus, hypothalamus, है ना? So this area, I want everybody to see. This is your thalamus. This is your sensory relay organ that you talked about in physiology, thalamus. Okay. So if they ask you where is thalamus, this is thalamus. On either side of the third ventricle. Okay. Now any one of you can answer beta. What structure is like a tadpole? Name a tadpole like structure which has a head, body and tail which goes alongside the lateral ventricle. ये क्या होगा? ऐसी क्या चीज है जो lateral ventricle के साथ साथ है? Anybody? A tadpole like nucleus in our brain alongside the lateral ventricle is called as the caudate nucleus. That is called as the caudate nucleus. That is called as the caudate nucleus. Clear everybody? Now everybody, if you are able to imagine for 5 minutes, we will solve it. Just give me 1 second. Behind the caudate, you have a similar area which is similar to the caudate. Both of them have some, in gross anatomy, they have some striations also. Okay. So behind the caudate, you have a part of the corpus striatum that you see here. This is called as the putamen. This is called as the putamen. Putamen. Medial to the putamen, we have a globular structure which is pale on gross anatomy, which is called as globus pallidus. Which is called as globus pallidus. Agnes, you are asking again about thalamus, hypothalamus. Wait, I will again repeat anatomy with MRIs and then I will show it to you and I will ask you to back correlate. Okay, I have a plan. Focus on my plan right now. Together, these putamen and globus pallidus, together the putamen and globus pallidus are lenticular, lens-like in shape. So what will we call them? Together these two will be called as the lentiform nucleus. Together we will call them as lentiform nucleus. Are you clear, beta? Okay, so what I am doing is I am repeating now for Shivam and everybody. Don't worry, beta. I am repeating, then I will ask you to do an applied anatomy. एक बार मेरे साथ दोबारा देखो. I am repeating, everybody. 1. What structure labeled is 1 in the image involved in Huntington's chorea? Okay. What structure of our brain is atrophied in Huntington's chorea and is labeled as number 1 in the image? Anybody? Caudate nucleus. The answer is caudate nucleus. Very good. What structure is labeled as number 2, which is your sensory relay organ? So what is your sensory relay organ? Number 2. So 1 is caudate nucleus, 2 is your thalamus. And I can see all the brilliant boys and girls already rocking the show. What is number 3? Number 3 is your lentiform nucleus. Okay, so my question to all of you brilliant children, I have never taught such a brilliant batch in my life. Now tell me, what is this Y-shaped structure that I am trying to draw, which is located between 1, 2 and 3? What is this? It is anterior limb, genu, posterior limb of internal capsule. So internal capsule is located between the caudate nucleus, between the thalamus and the lentiform nucleus. That is where you have your internal capsule. Okay. Now, this is the deep part of the brain. I will give me 1 second. I just want to make sure that you are all following my concept. This is your frontal lobe, and to the best of my knowledge, CT brain. This is the best anatomical discussion that you can ever have. So listen to this video again at 2x speed. Okay, but see this part. Can you still see a large fissure here? This is your Sylvian fissure. So if you see the Sylvian fissure, that means still we are somewhere at the level of temporal lobe, and this is your occipital lobe at the back. Above this section you should have parietal lobe, because Sylvian fissure will not be seen after this. Okay. Now this image is at the level of basal ganglia. It is at the level of your lateral ventricles, anterior and posterior horn. My question to all of you is this. Let's see how many of you can answer. Let's see how many of you can answer. Is this normal, abnormal? Is this arrow marked area normal, abnormal? This white, what is white? Hyperdense. What is this? This is a hematoma, a blood clot. This is a hematoma. Okay. My question to you is, some of you might ask me, sir, ये hematoma है तो white क्यों दिख रहा है? Why it is white? Because when the blood clots, RBCs come close together. When the RBCs come close together, the globulin, the protein gets condensed together. Electron density increases and it becomes hyperdense. So you can see a hyperdense hematoma. Where? Is this in the caudate nucleus? Is it in the thalamus? Is it in the putamen? Any one of you can tell me. 1, 2, 3. What is your answer? Where is the hemorrhage located? Is it in the caudate? Is it in the putamen? Is it in the thalamus? So we already know by now that caudate was somewhere here, thalamus was here. So this must be in the putamen. This is a bleed in the putamen. This is a bleed in the lentiform nucleus. It is in the putamen. Now that leads me to my pathology knowledge. Let's all relax for a moment. We are trying to enjoy the art of medicine. I want you to have patience. Listen to me. Okay, patience. Listen to me. Okay, बच्चे देखो. Suppose this is your frontal lobe. This is where we have the temporal lobe. Okay. Suppose this is where we had the internal carotid artery, and it gave a branch going here which was ACA and a branch going here which is MCA. Okay. Okay. Listen to me, everybody, Nikhil and everybody. I'll try to explain. Okay. Now suppose your heart is pumping blood at high pressure and you are having a patient with hypertension. Now hypertension, there will be high pressure in the internal carotid artery. Now if you ever see in a dissection hall, you will see the diameter of middle cerebral artery will be more than the anterior cerebral artery. Middle cerebral artery is larger. So the pressure goes into the middle cerebral artery. More than the anterior, it goes into the middle cerebral artery. From the middle cerebral artery, there are branches which are going to supply the lentiform nucleus. These are called as lenticulostriate branches, or we can call it as Charcot artery. These arteries, because of repeated hitting by high blood pressure, they develop lipohyaline. Because of, if they are hit by hypertension, these vessels become filled with some lipid and hyaline material, lipohyalinosis. They become weak and they dilate microscopically to form Charcot-Bouchard microaneurysms. They cannot be seen in radiology. They are microscopic aneurysms. And if they rupture, you develop brain hemorrhage. If they rupture, you develop brain hemorrhage. So are you able to understand my point? The question is, most common site of hypertensive bleed in the brain is? Anybody can answer this question. Most common site of hypertensive bleed in the brain is? The answer is basal ganglia, or they might say putamen to be more precise. Clear? Are you able to understand this? So we understood, we discussed this in anatomy. There is an artery called as Charcot artery or brain hemorrhage. In pathology, they will say Charcot-Bouchard microaneurysm seen in hypertension. Okay, so hypertension is a classic cause of parenchymal bleed. I'm repeating again for Srinath and everybody, but I want you to appreciate that sometimes you may not be able to follow, not because of me, but because you are not doing the anatomy and the pathology part right. So my suggestion is, if you find it difficult, do listen to my video again. I will leave this video on the app. You can listen to it again, but try and understand better. Try to understand. है ना? एक बार सीखने की कोशिश करते हैं. From the internal carotid artery, there is a branch which is called as middle cerebral artery, which gives superior branches which are called as lenticulostriate branches. In hypertension, these arteries undergo lipohyalinosis and they dilate to form Charcot-Bouchard microaneurysm, which if they rupture, it will cause hypertension. So now I am repeating for all of you. Now tell me, anybody, do you see in front of you a patient with hemorrhage in the putamen? What is the cause? Most likely cause in this particular case should be hypertension. Okay, so this is how, when I look at radiology, I can tell you the cause. This is a patient with hypertensive bleed. Immediately I am having a MCQ. Can you tell me what are other sites of hypertensive bleed? Most common is putamen, but where else can you have hypertensive bleed? It can also be seen in thalamus, pons, cerebellum. So what are the typical sites of hypertensive bleed in the brain? Basal ganglia is most common, that is clear. But other than basal ganglia, hypertensive bleed can also be seen in thalamus, pons, cerebellum. Clear? Everybody understands? Clear? Now, Now they are not in the frontal lobe, they are in the deep part of the brain. So these lenticular-striate branches are going into the deep part of the brain. Can you see? In the basal ganglia, in the deep part of the brain. That is where you see the hypertensive bleed. Okay, Aditi Gaur? Okay. Now let's go further. Let's go further. Now when I reach on the uppercuts, I can see now the frontal lobe, the falx cerebri, lateral ventricle, parietal lobe, occipital lobe. Because when you stop seeing the Sylvian fissure, when you don't see the Sylvian fissure on the lateral part, this must be the parietal lobe. You can see the parietal lobe sitting there. Clear? Okay. Now also tell me, I'm sure you can tell me. Okay. Between the connecting the white matter on either side, you have these commissural fibers. Can anybody identify what could this be? Okay, and after this, maybe I can take, after this I'll take some of your questions. But can you see here, this is your, what is the structure that I'm trying to draw? Corpus callosum. This is your corpus callosum. Two questions for you, beta. Two questions. If a alcoholic develops corpus callosal necrosis, what is the syndrome called as? Okay. If an alcoholic develops necrosis of corpus callosum, what is the syndrome called as? Syndrome is called as Marchi-Fava-Bignami syndrome. Okay. If you have necrosis of corpus callosum in an alcoholic, it is called as Marchi-Fava-Bignami syndrome. And one tough concept for you, very tough concept, I want your full focus. Okay. Suppose this is your embryological brain. Suppose these are your lateral ventricles. These are your white matter bundles, fibers of white matter, which are called as bundles of Probst. Okay. Embryologically, when these fibers will migrate, they will cross over, patience, they will cross over and they will become like this. So corpus callosum is actually formed by these bundles of Probst which are present on either side of the midline. When they migrate and they cross over, you form the corpus callosum. Now suppose, listen to me, it's a tough concept and I will repeat it also. It's a tough concept. Suppose you have a fetal insult at this time. Suppose you have some hypoxic event, some infection, some insult happening at this time. What will happen? Corpus callosum will be not formed. Not forming is called as agenesis. Okay. So what will you see? Then you will see lateral ventricles will be parallel to each other. If the corpus callosal agenesis is there, lateral ventricle will be parallel to each other. It will be parallel to each other. The anterior horn, posterior horn will be parallel to each other, which look like the wheels of a racing car. So we say racing car sign. Okay. I'm again repeating. I'm repeating beta. देखो अब एक बार पेन छोड़ के सुन लो मेरी बात. ठीक है. All I said was corpus callosum पे दो MCQ है. If in an alcoholic you have necrosis of corpus callosum, it was described by Marchi-Fava and Bignami. We will call it Marchi-Fava-Bignami syndrome. Okay. Secondly, in intrauterine life, if there is a problem in development of corpus callosum, the lateral ventricle will appear parallel to each other, which is called as the racing car configuration, which you might have mugged up and you might have seen in a previous FMG and previous NEET PG exam. Are you clear, beta? Racing car appearance seen in agenesis of corpus callosum. Okay. Now what I'll do is, because you all have been such good boys and good girls, before I show you further integration into the diseases, I will do a quick revision and I will ask you some questions. You have to set the chat box on fire. Okay. What is the structure labeled as 1? What is the structure labeled as 1? That is your, okay, maybe instead of 1 I can put arrows, otherwise the numbers will confuse. What is the arrow? What is my arrow pointing at? Orbit. What is my arrow pointing at now? That is your frontal sinus. Frontal sinus. Temporal lobe. Temporal lobe. What is this? Cerebellum. What is this? Pons. Between them, fourth ventricle. Between them, you have your fourth ventricle. CP angle. CP angle. Clear? Sella turcica. Sella turcica. Clear beta? Okay, now let's do it again. ये वाला करेंगे अब, ठीक है? 5 मिनट एक्स्ट्रा ले लेंगे लेकिन करेंगे सब. Okay? Tell me now. Frontal lobe, temporal lobe, pons, cerebellum. Okay, now listen to me. Now tough question. Amygdala, uncus, hippocampus. Anteriorly amygdala, medially uncus, posteriorly hippocampus. And this area is your suprasellar cistern. Suprasellar cistern. Clear बेटा? अब ऊपर आते हैं. Frontal lobe, temporal lobe, Sylvian fissure, midbrain, cerebellum. And now please see, this is the part which I was describing as the optic tracts, interpeduncular fossa, and एक बच्चा पूछ रहा था ना मेमोरी बॉडी कहां पे होगी? यहां पे होगी बेटा. So on MRI I will show it better, but in the interpeduncular fossa you have the mammillary bodies. So the area that I have now marked as 2 white dots is where you have the mammillary bodies. Mammillary bodies. Clear beta? Now are you able to revise now? Okay. And in this section we saw that we could see the frontal lobe, insula, Sylvian fissure, temporal lobe, occipital lobe, part of the hypothalamus, aqueduct, third ventricle, lateral ventricle, and we saw the columns, anterior pillars of the fornix. Other name of Sylvian fissure is lateral sulcus. Shivam Gaur beta, lateral sulcus. And in this section I taught you this is falx, anterior horn of lateral ventricle, posterior horn of lateral ventricle, third ventricle, thalamus, caudate, lentiform nucleus. In between you have the internal capsule. Okay. And this is your falx, frontal lobe, parietal lobe, occipital lobe, lateral ventricle, area of the corpus callosum. Okay, clear everybody? Okay. What was the hyperdense structure in front of the interpeduncular fossa? I don't know what is the baby saying here. Okay, tell me child, beta, I can't understand where in front of interpeduncular fossa do you see? Now see, I am zooming in for you. I am removing myself for any confusion. This is your crus cerebri, optic tract, interpeduncular fossa. Okay, where is putamen? Very important question that one बच्चा has asked. देखो बेटा, lentiform nucleus के 2 पार्ट होते हैं. बाहर वाला पार्ट, अहमद बाशा, the outer part is your putamen and the inner small part which is pale in color in anatomy is called as globus pallidus. Together we call them as lentiform nucleus. Okay, now are you clear everybody? Are you able to understand? Okay, so what we will do is, now I know that some people are saying where is parietal lobe? बेटा अब देखो बेटा, अभी इसको देखो बेटा. Okay, अविरल शर्मा प्लीज सी देखो, अभी दिखा क्या बड़ा सा कोई सल्कस नहीं ना, हम उसके ऊपर आ गए हैं. सो यहां पे देखो, इसको देखो, ये can you see this is your part of your Sylvian fissure that is still visible. So that is at the level of temporal lobe. Once I come above the level of Sylvian fissure, that is parietal lobe. I will just take an anatomy image to make sure that you follow. See, so this is what is your Sylvian fissure that we are trying to follow. Above the Sylvian fissure level, we can start to see the parietal lobe. Above the Sylvian fissure, we see the parietal lobe. Okay. Now, regarding the thalamus and hypothalamus, I want you to have more patience. I will repeat this with MRI when we go deeper into the MR anatomy. But my goal is not only to integrate radiology with anatomy, my goal is to integrate it with surgery and medicine. I want you to see this image 100% every year. One exam they are asking this image. ओके अब ब्लड वेसल भी रिवाइज करेंगे, बार बार करेंगे. एमआर एंजियोग्राम भी दिखाऊंगा, सीटी एंजियोग्राम भी दिखाऊंगा. डोंट वरी, मल्टीपल टाइम बात करेंगे. डोंट वरी, एक बार बेसिक आ गया हमारे पकड़ में, आगे बढ़ते है ना. नाउ एनीबडी टेल मी, ओके एनीबडी टेल मी व्हाट इज दिस स्ट्रक्चर? दिस लुक्स लाइक अ हेमेटोमा. नाउ समबडी वाज सेइंग सर ये बोन से कैसे फर्क है, कैल्शियम से कैसे फर्क है? ट्राई टू सी. द मोर वाइट थिंग इज बोन. This is your brain. In between bone and brain, you can see this is a hematoma. Can you see here? Hematoma. You can see a hematoma here. Clear? Now, try to understand what is happening. I will give you the real reason why what is happening. Then we will try to solve the MCQ. Suppose this is your skull bone. This is your skull bone. These must be the sutures. Remember, in between different skull bones, you have sutures. Okay. Now, listen to me. Don't get into the answer. अभी answer मत बताओ, पहले समझ लेते हैं, ठीक है? फिर हम solve करेंगे, ठीक है? Now, skull bone, like any other bone, will be covered by periosteum. Skull bone will be covered by periosteum. Okay? Clear? And inner part of the skull will be covered by endosteum. Okay. Skull is covered by periosteum and endosteum. The periosteum and endosteum are connected to each other at the level of sutures. At the level of suture, the periosteum and endosteum are fused. Okay, at the level of sutures. Now listen to me everybody. This endosteum forms the outer layer of dura. Dura has two layers. Dura has a inner layer. Dura has a inner layer which is the meningeal layer, inner layer which is the meningeal layer, outer layer which is the endosteal layer. Do you remember? Dura matter has two layers, the meningeal part and the endosteal part. So endosteum is fused to the dura. Okay, it is the part of the dura. Now try to imagine for a moment. Okay, I want all of you to listen to me. Okay, just give me 1 second. है ना बेटा, थोड़ा सा मेहनत करेंगे, है ना, थोड़ा सा focus करते हैं, focus. Between the skull and the dura, there is a blood vessel going on here. This blood vessel is supplying the meninges. It's giving the blood supply to the meninges. This blood vessel is called as the middle meningeal artery. This blood vessel is called as the middle meningeal artery. Yeah, middle meningeal artery. Now suppose you have an accident, okay, hitting the skull, causing injury to the middle meningeal artery. What will happen? If the middle meningeal artery is ruptured, what will happen? You will start seeing blood accumulating. Where? In the extradural space. Outside the dura, in the extradural space, blood will start, hematoma will start accumulating. But can it cross the sutures? it cannot cross the suture lines. Can you tell me why? Cannot cross the sutures. Can you tell me why? Because the dura, outer layer of the dura is endosteum, which is fused at the sutures. It cannot cross the sutures. Very important MCQ, multiple times asked. Don't get it wrong. Extradural hematoma is due to rupture of middle meningeal artery, cannot cross the sutures. Now it is an arterial bleed. So artery is rupturing, the blood is coming out. What will happen? It will further expand. It will further expand like this. It will further expand like this. And you will see blood accumulating between the dura and the skull. This is called as extradural hematoma. Okay. This is called as extradural hematoma. Clear? Due to rupture of middle meningeal artery. Shape. Biconvex in shape. Biconvex in shape. Okay. Are you clear? Shiva, I am speaking 100% English. If I say something in Hindi, I repeat it 10 times in English again. Okay, Shiva Rajani, I am totally in love with you. I will say 10 times more English. Don't worry, beta. Now tell me, beta, Shiva. Clear? Tell me, what is this area? Now, my question to all of you is, why the hematoma is only till this point? Why it is not going beyond it? Because this is where you must have the coronal suture, lamboid suture. This is the area of the sutures. Extradural hematoma cannot cross the suture line. That is why it is becoming biconvex. Are you clear? So immediately after the accident, you lose consciousness, then you regain consciousness, and then the hematoma expands and you again lose consciousness. What is this called as? Lucid interval. Which brain hemorrhage shows lucid interval? The answer is EDH. Now, just to show you one anatomical question here. On a skull, if you see the skull in anatomy, they talked about a point called as pterion. Have you heard of pterion? Which is between the frontal bone, parietal bone, temporal bone, and the sphenoid bone. Can you see there is a H-shaped point between the frontal bone, parietal bone, sphenoid, and the temporal bone called as pterion, which is the landmark for middle meningeal artery. So if they ask you in anatomy, what is the significance of pterion? This is the anatomical landmark for middle meningeal artery. Rupture of middle meningeal artery leads to extradural hematoma, EDH. Everybody clear? Everybody clear? Clear? Everybody understands? Okay, very good. Now, because you are so smart children and you think you know it all, I will give you a tough question, AIMS level question now coming your way. Let's see how many of you can answer in the next INI set. EDH can cross midline. True or false? Okay, everybody now tell me. Extradural hematoma can cross the midline. True or false? Let's see how many of you can answer it correctly and get a seat in the central exams. EDH can cross midline. True or false? Anybody tell me now. Tell me. Now what happens in the frontal area? What happens here? You don't have any suture here. Although there is a rudimentary suture in the fetal life called as the metopic suture, but that is rudimentary. So suppose you have a hematoma, extradural hematoma in the frontal area, what will happen? It can cross the midline. It can cross the midline. So EDH, especially if it is in the frontal area, it can cross the midline. This is a true statement. Okay. It cannot cross the suture, but can cross the midline, leads to lucid interval. Clear? Middle meningeal artery is the cause. Okay. Usually, most commonly it is arterial. Okay. My question to you is this. Okay, everybody. Everybody answer now, बच्चे. देखो, बच्चे सोच के बताना, मेरे को सोच के बताना. Can you see a hematoma here? Can you see a blood clot here, hyperdense blood clot here? What is happening? Tell me. Crosses the suture. Crosses the suture. Okay, it is crossing the suture. So that means it cannot be EDH. If it is crossing the sutures, it must be subdural hematoma. It must be subdural hematoma. I will explain. Give me 1 second. Listen to me, everybody. Listen to me, beta. Socho, suno. Suppose this is your dura. Suppose this is your dura. These are your gyri sulci. And you know by now, gyri sulci are covered by the leptomeninges, pia and arachnoid matter. Okay. Now, give me 1 second and listen to me. Okay, just listen to me, beta. You know it, but listen to me. Okay. Between your dura and your arachnoid, you have bridging veins. Between the dura and arachnoid, you have bridging veins. Now, there are two possibilities. Either you are an old person or alcoholic. What will happen in old and alcoholic people? Brain will atrophy. There will be atrophy of brain. Or you are violently shaking the head of the baby. That is seen in shaken baby syndrome. Now try and imagine now, listen to me. Okay. Bache, Viral Sharma, I will explain to you better. Don't worry. Listen to me, bache, ek baar sona mere saath. Okay, listen to me. If the brain is atrophying, these bridging veins will become taut. They will come under tension and they might rupture. So that is why you will see a hemorrhage collecting below the dura. The hemorrhage will be collecting below the dura and between dura and arachnoid. What is this? Subdural hemorrhage. But if you have time and trust, you will see dura by the time we reach the midline is folded. When you reach the midline, the dura has a fold called as falx. Okay. So SDH cannot cross the midline because it is limited by dural folds. SDH cannot cross the midline because it is limited by dural folds like this. Are you clear, beta? Are you able to understand? Are you understanding this, beta? Okay. Should I repeat? So, subdural hematoma is seen in old people, alcoholics, or in child abuse patients where there is rupture of bridging veins. Subdural hematoma, the shape will be concavo-convex. It cannot cross the midline. It is limited by dural folds like falx, limited by tentorium. It cannot cross the midline. Shape will be concavo-convex. So for Shanmugapriya, I am repeating again. Beta, dekho, Shanmuga, please see with me. Okay, I am removing myself. Just see the difference, beta. I will repeat in short. This is your EDH. And this is your SDH. Alcoholics also, Anisa and Beju, alcoholics also have cerebral atrophy. It is known, although you know some children think it is fashionable, but alcoholics also have cerebral atrophy. Very important. See, now are you clear, beta, here or not? EDH is localized because it cannot cross the suture lines. It expands towards the brain. It expands towards the brain. It is biconvex. SDH is due to rupture of bridging veins. It cannot cross the midline. It is seen in old people, alcoholic, child abuse, concavo-convex. Okay. Now that must, Sarthak, you must be having some local issue in your phone or internet, beta. Nothing is a problem here. Okay. Are you clear, beta? EDH, SDH. Now, one more question coming your way. Conceptual question. What are these? What are these black lines? These are your sulcal spaces. These are your sulcal spaces. Now, sulcal spaces are dark because they are filled up of CSF. Sulcal spaces are dark because they have CSF. Okay. Now try and imagine this particular case. Okay, don't be fooled by this white thing. This white thing is your pineal gland, and you know by now that pineal gland can calcify normal people after 10 years of age. In adults, after 10 years of age, pineal often calcifies. This particular calcification is nothing but choroid plexus calcification. Both of these are normal areas of calcification. Okay. Now, one बच्चा is saying यशस्वी देवाग्नि के child abuse में क्यों हो जाता है SDH? मैं समझाता हूं बेटा. Suppose you are violently shaking the head of a baby. The baby does not have head control. The dura will have shearing action over the arachnoid. It will shear like this. And during that shearing force, the bridging veins rupture. That is why subdural hematoma is classic of shaken baby syndrome. You might also have read in ophtha, retinal hemorrhage, subdural hemorrhage, when infant is being violently shaken by the parent. Clear? Now, let's see now. Everybody now. My question to you is this. What is this area? What is this area? What is this area? Anybody can tell me. These are your sulci. But why are these sulci appearing hyperdense? Why are the sulci appearing hyperdense? Anybody can tell me? Okay. Sulci are appearing hyperdense because there is hemorrhage there. So what kind of hemorrhage is this? This is subarachnoid hemorrhage. This is subarachnoid hemorrhage. And why would somebody develop subarachnoid hemorrhage? Subarachnoid hemorrhage could be because of trauma. But other than that, excluding trauma, it is because of rupture of berry aneurysm. It is because of berry aneurysmal rupture. How will the patient come to you? Patient will come to you with worst headache of his life. Worst headache of his life. Or they can also write thunderclap headache. Worst headache of his life, thunderclap headache, or they will say neck rigidity, because blood in the sulcal spaces will irritate your meninges and it will cause neck rigidity. Worst headache of his life, subarachnoid hemorrhage. So if you now notice, okay, bache, what I have done is in the first phase of the class I was showing you normal anatomy. Then I am teaching you how to look at brain hemorrhages. I have shown you hypertensive bleed, clear. Parenchymal bleed in the basal ganglia. I have shown you subarachnoid hemorrhage, subdural, extradural. Any time you want to revise radiology, just listen to my video again in 2x speed. That is all. Revise 100% questions from the class. Nothing else will be asked. Okay. Just listen to me again and again. They will say patient comes to you with sudden severe headache. Look at the CT scan, diagnose, see the sulcal hyperdensity, mark subarachnoid hemorrhage, come back with a top rank. Okay. This causes very severe headache, like the kind he has never experienced before. Okay. My question to you is this. Why it happens? It happens because of aneurysmal rupture. So suppose they ask you in the exam a question, what is the investigation of choice for a cerebral aneurysm? What is the trauma exclude मतलब इशिका देखो सबसे common cause of subarachnoid hemorrhage is trauma, but if there is no history of accident trauma, then it is due to a ruptured aneurysm. Excluding trauma, excluding traumatic causes, most common cause of subarachnoid bleed is a ruptured aneurysm. Okay, now my question is this. Okay. Now, I have the entire night with me, entire day with me. I am totally at your service, bacha. Some bacha is saying dinner break. Let's do the brain hemorrhages and then maybe take a quick break and come back. If you want to do that or you want to do in continuity, I am happy either ways. Okay. Now tell me, investigation of choice for cerebral aneurysm. Now, cerebral aneurysm is a cause of subarachnoid hemorrhage, and subarachnoid hemorrhage you will see on a CT scan. Okay. You will see on a CT scan. So it is better to do a CT angiogram at that same time to look for the cause. Investigation of choice for cerebral aneurysm is a CT angiogram. I will show you how it looks like. Now this is a CT scan image. Everybody look at it. Do you see the brain parenchyma? No. What do you see? We are able to see the blood vessels. We are able to see the blood vessels. That means this CT scan has been optimized to look at the blood vessels. CT angiogram. My question to all of you is, do you see this particular dilatation? Okay, brain hemorrhage कर लेते हैं फिर सोचेंगे. Do you see, I want all of you, look at this area beta, look at this area, यहाँ पे देखो बेटा. Do you see there is a dilatation, a secular dilatation at the branch point? That is what is called as berry aneurysm. That is what is called as berry aneurysm. Okay, clear? Tell me, investigation of choice for cerebral aneurysms is CT angiogram. But now is the trick. Now is the trick. If they say most accurate, now most accurate can be written as gold standard. So just one more image and after we finish hemorrhages, we will take a break. Okay, we'll take a break. Don't worry. Okay. After the hemorrhage, because hemorrhage have to be done together, beta. If they say what is the most accurate or gold standard investigation to find a cerebral aneurysm, can anybody answer and tell me? Can any one of you, the brilliant children today, tell me, everybody, what is the gold standard or the most accurate for cerebral aneurysm investigation? The answer is digital subtraction angiogram. The answer is digital subtraction angiography. Have you heard of this before? Digital subtraction angiogram. I will show it to you, beta. I will show it to you. Don't worry, I have full time with you, beta. Don't worry. I want all of you now just to look at the screen. Just look at the screen. Don't panic right now. It is just a small video clip I will play and just see the image. Okay, just see it. Okay, I will play it again, beta. Can you see? Okay, I will now get myself back. Okay, can you see, beta, in the image? This is the internal carotid artery dividing into the midline branch. The midline branch is the anterior cerebral artery. The lateral larger branch, which is going towards the Sylvian fissure, is your middle cerebral artery. This is the middle cerebral artery. This is the anterior cerebral artery, internal carotid artery. We have given dye by doing a catheter. We are injecting dye through a catheter. Through the femoral artery, we are taking a catheter into the carotid artery, injecting the dye, invasive technique, and looking at the arteries. After the arteries, you can see the dye will go into the capillaries. The dye goes into the capillaries and then it goes into your venous sinuses. So I'm sure you can see now, these are your venous sinuses. So DSA, you could see a arterial phase, capillary phase, venous phase. This is how a DSA looks like. DSA is most accurate, gold standard for aneurysm. I know you want a break, but listen to me right now. A very interesting things I will show you. Okay. Just see with me, beta. So suppose you can see here there is the aneurysm. I have taken a micro catheter into the aneurysm. Can you see with me, beta? So take a snapshot also. Take a snapshot. Share it on Instagram. Can you see? Can you see a micro catheter gone into the aneurysm? And then we are using platinum coils to obliterate the lumen of the aneurysm. This is what you have read in your medicine as endovascular coiling. We are doing coiling of an aneurysm. Okay, I will pause at the right time. Can you see? You are trying to put that wire into the entire lumen of the aneurysm to obliterate it so that the rebleed does not happen. Now always remember, now see here, I'm pausing it here. Can you see now? Always remember, in a patient with aneurysmal rupture, first bleed, after the first bleed, sometimes the patient is stable. But if the patient has rebleed, it is usually fatal. So after we confirm that there is an aneurysm on CT angiogram, we take the patient for the gold standard, which is DSA. Along with DSA, we do a endovascular coiling. This is endovascular coiling. Okay, so don't worry. If you are not able to take a screenshot, don't worry at all. You can see the video again at 2x. That is the beauty, because short sessions of radiology, high yield, revise. Are you clear? Now, I am going backwards, Vita. Okay. So let us revise the questions. Investigation of choice for any brain hemorrhage. Investigation of choice for any acute brain hemorrhage is NCCT. Investigation of choice for any acute brain hemorrhage is NCCT. Investigation of choice for cerebral aneurysm is CT angiogram. Gold standard for our aneurysm in the brain is digital subtraction angiogram. Okay. And final question before the break is this. Okay. Now I want you to put your thinking hats on. Okay. Just relax. Aap thake bhi nahi hai. You're not tired. There is no problem in life. No exam happening. Just we are trying to enjoy what God has made, what human life is all about, and we are trying to understand what is going on. Any one of you can tell me, beta, what is the problem here? Okay, after this we will take a 10 minutes break and come back and do the rest of the part. Don't worry, I have full time, don't worry. Anybody, what is the problem in this patient? There is a hematoma. There is a blood clot. Where? Where is the blood clot located? Anybody can tell me. Okay, definitely there is pineal calcification, Rashika, I can understand. There is choroid plexus calcification, I can understand. But there is a hematoma. Where is the hematoma? It is in the frontal lobe. So there is a lobar hematoma. Is it in the basal ganglia area? Is it in the basal ganglia, thalamus, pons? No, it is in the lobe of the brain. Now, if you see a lobar hematoma, always look at the age of the patient. If suppose I say this is an old person, can you tell me what is causing this hemorrhage? Yes, Amrita, Isha, Saranya, Karthik, Sai Nadu, tell me. Agar ye lobar bleed hai, so this is not the classic location for hypertensive bleed. This is not basal ganglia, this is not thalamus, it's a lobar bleed. If you see a lobar bleed in an old person and you are appearing for your NEET PG exam, what will you mark as the cause? This is not hypertensive bleed, cause site hi nahi hai uska. Hypertensive bleed to zyada basal ganglia mein hota hai beta, Shubham. Now tell me, Shubham, and what is the cause? This is where we think about cerebral amyloid angiopathy. Old people with an atypical site, lobar hematoma, think about amyloid angiopathy. Are you clear? Cerebral amyloid angiopathy in old people in the blood vessel. If you have that beta amyloid deposit causing weakening of the vessels, lobar bleed. So lobar hematoma in a old, think about cerebral amyloid angiopathy. Are you clear, beta? ये parenchymal bleed है. मैं देख रहा हूँ प्रशांत कह रहा है कि ये ब्रिजिंग वेन्स, ब्रिजिंग वेन्स रप्चर होती तो सबड्यूरल होता. Subdural will be seen outside between the arachnoid and dura. This is in the brain parenchyma. So I have to think of amyloid angiopathy. Second question. Suppose this was young person, a child. तब क्या सोचते हैं? Okay. Anybody? Henry Patel, tell me, beta. Okay, no, Henry Patel is saying, sir, DSA. But even before you DSA, you need some anatomical localization. That is why first you will do CT angiogram on the CT table itself. If you have a lobar bleed in a child or a young person, think of underlying AV malformation. artery connected to directly to a vein with a bunch of vessels called as nidus is called as arteriovenous malformation. No capillaries, artery connected to vein with a nidus is called as AVM. So a lobar bleed, a parenchymal bleed in a child, always keep in mind it could be a AV malformation. Okay, so this is how we think. If you have now noticed, I have increased the level. I was talking about basic things, then anatomy, then I'm trying to tell you how to think. How to think is the key in radiology. That is why in radiology we need some shorter, high yield sessions to push the concepts. Okay, that is why I'm reinventing the education structure here. I will do short sessions, cover everything, then I will come to all the face-to-face centers with a test, with a test paper. And again we will do the application part, and after that I will guarantee you no question wrong in your exam from radiology at least. Okay. Now Pushti Jain is saying, sir, it looks like a tumor. I will show you tumors. Don't worry after this. Okay, I will show you tumor. So now is the time. I think it is a good idea to take a break, 15 minutes, come back after 15 minutes, and we will see infarction. I will teach you how to look at infarct, other CT pathologies. Right now I have shown you only hemorrhage and CT anatomy. After this, come after 15 minutes, please. I am waiting for you. So Ashwati, nidus means an abnormal bunch of vessels connecting artery to the vein in AV malformation. So the normal capillary is not there, Ashwati. That is nidus. Okay, a nest of vessel like Vipul is saying. Okay. And for the satellite centers, I will upload the test with a video solution. Don't worry, beta. Okay, so come back in 15 minutes, beta. Everybody come back in 15 minutes. Prashant Singh CA was cerebral amyloid angiopathy. Cerebral amyloid angiopathy. Okay, how to, Kiran, how to identify suture? By your anatomical understanding, beta. Sometimes it is not seen, but we can understand. Na, from our knowledge, we know this is the area where we must have the coronal. So I think before we start again, let us take some doubts. I think some bachas has asked a question regarding like what is lucid interval. So what happens in EDH is the patient becomes unconscious because of the impact of the injury. Then he becomes conscious again. Then because the blood accumulates between the dura and the skull, it compresses the brain and the patient becomes unconscious again. So lucid interval is the zone of consciousness in between the two areas of unconsciousness. And one bacha is saying, sir, why subdural hematoma cannot cross the midline? Because it is limited by the dural folds, that is falx cerebri. Because of the falx, it cannot cross the falx. Okay. Okay, everybody clear? One bacha is saying NF2 or deafness में कहाँ पे क्या होता है? निखा बेटा NF2 में the patient is prone to develop vestibular schwannomas, which is a common CP angle tumor. So you see the tumor between the at the cerebellopontine angle, CP angle. Okay. What is present between the colliculi and the cerebellum? This one, huh? But in between the colliculi and the cerebellum, if you see, this is all CSF. These are all your perimesencephalic cisterns. So I'm sure you remember around the midbrain you have cisterns, CSF spaces. So that black thing is the CSF space that you see here. Okay, beta? Why EDH cannot cross the midline? Faye Aslam, I said EDH can cross the midline. STH cannot cross the midline. I think bacha aap confused ho gaye. Aslam Sheikh. Okay. Everybody clear? Okay. Nabeen Sai is saying so macular sparing क्यों होता है? So in uncal herniation, the blood vessel that is compressed is posterior cerebral artery. Posterior cerebral artery supplies the visual cortex. But in the visual cortex, the area which is responsible for macular vision is supplied both by PCA and MCA. So because it has dual supply, it is spared. Okay, everybody clear? So now what we'll do is we'll start again. Okay, we'll start again, and I see there are variety of doubts, and that is how radiology is actually. Radiology seems like a small subject to the medical students, while it is a highly integrated specialty. So it takes time to absorb things, and that is why I have divided into smaller parts, so that after my session you can just go through the video again and make your notes, clean it up, and then revise. Okay, so let's start now. Let's start now. Everybody, let's start now with the first image now. Let's see the first image after the break. Are you now able to? Everybody, welcome back. Welcome back. NCCT is non-contrast CT, beta, non-contrast CT. Everybody now see. Can you see this is an area which is appearing dark? So in CT scan, if you see something dark, what do you say? Hypodense area. Okay. This hypodense area is shaped like this. It is narrow in the center and broad towards the outer part. Whenever we see such a shape, we will call it wedge. What do you see? There is a wedge shaped hypodense area. Wedge shaped hypodense area. Now, if I take you back to your anatomy days, can any one of you tell me the occipital lobe of our brain is supplied by which artery? This occipital lobe is supplied by which artery? It is supplied by posterior cerebral artery. So the occipital visual cortex, the occipital lobe is supplied by the posterior cerebral artery. But many children forget, even your thalamus is supplied by PCA. You can go and check it out also. Thalamus is supplied by PCA, posterior cerebral artery. Okay. Now, anterior part of our body, of our brain here, is supplied by ACA. Anterior part is supplied by ACA, anterior cerebral artery. This anterior cerebral artery has some recurrent branches. It has some recurrent branches which supply the caudate nucleus. So ACA not only supplies the anterior part, is also supplies the caudate nucleus with recurrent branches. I am sure some of you might have heard of recurrent artery of Hubner. Okay. Now please see with me. Patience. Please see with me and tell me, do you see the wedge-shaped hypodense area is corresponding to a vascular territory? Do you see that this vascular territory is this? Which artery territory is this? Anybody can tell me? Middle cerebral artery territory. So this patient has actually a wedge-shaped hypodense area corresponding to MCA territory. Okay, MCA territory. So if I now remove all my annotations, are you able to see there is a dark area? This one, please see everybody, please see all the bachas, this area, this dark area in the brain parenchyma, which is shaped like a wedge corresponding to MCA territory. What is your diagnosis? This is a brain infarct. This is a brain infarct. Are you clear? Are you able to understand this? This is a brain infarct. Now you might ask me, sir, why is the infarct shaped like a wedge? Please try to understand. If you have any solid organ, okay beta, if you have any solid organ, if this is the artery which supplies this organ will enter the center, then branch out towards the periphery like this. So vascular territories in our body are typically shaped like a wedge. So if this artery is occluded, what will happen? You will see an infarct. Infarct will shape like a wedge. Are you clear? Now Joel is saying, sir, why it is more dark? I will explain to you, beta. I will explain to you. But don't worry. So far I have explained this is a middle cerebral artery territory, wedge-shaped hypodense infarct. Okay. Now I am Aksan Nayab and Aroma Mary. I am asking you another question, beta. If the main artery is occluded, you see a wedge-shaped infarct. But if a branch of the main artery is occluded, if it is just a small branch which is occluded, then what will happen? You understand? If the middle cerebral artery is occluded, we saw an infarct like this. Are you able to see this here? This is how we see it. Okay, wedge-shaped infarct. But if a small branch is occluded, what will you see? If a branch is occluded, you will see a small infarct less than 1.5 centimeter in diameter, which is called as lacunar infarct. Okay, are you clear, beta? If the large vessel is occluded, you will see a wedge-shaped infarct. If a small vessel is occluded, you will see a lacunar infarct. Can anybody tell me where is a lacunar infarct in this particular image? Now this is an image directly from my notes which was asked in a NEET PG exam. So you can just take a picture, or you want to just revise it by going through the video again. This is the lacunar infarct. Are you able to see this here? This one. A small hypodense area in the thalamus, lacunar infarct. These are your lateral ventricles, third ventricle, pineal gland, choroid plexus. Don't get confused. The answer is lacunar infarction. Okay, everybody clear? So I'm repeating it for the children who have so far not understood. So what I'm trying to tell you is that before the break, I was teaching you how to look at brain hemorrhage. But now I'm telling you how to look at brain infarct. So in the exam, they might show you a large infarct, wedge-shaped hypodense, or a small lacunar infarct, which is small, less than 1.5 centimeter in diameter, which is due to a small vessel getting occluded. Are you clear? Able to follow? Okay. Okay, are you clear, beta? Okay. Now, this lacunar infarct is not there in the image book, so you can add it there. Okay. Now my question to you is this. Okay. Okay, my question to you is this. I will show you. Are you clear, beta? Somic, size, clear? Okay. Now my question to you is this. Suppose you have ischemia in the brain. What is ischemia? Reduced blood flow. Suppose you have reduced blood flow to the brain. One blood vessel gets occluded. You have ischemia. What will happen? Now, if there is blood is not coming to the brain, oxygen will not come there. If oxygen will not come, all that Krebs cycle, ATP production will not happen. You will have reduced amount of ATP there. If the ATP reduces, the neuron will start to die and it will have blockage of the function of sodium potassium ATPase. Clear? Okay, I am again repeating, beta. Ischemia, ATP will reduce, there will be sodium potassium ATPase blockade. Then what will happen? Then what will happen? The neurons will be swollen and dead. There will be neuronal swelling as well as death. This part we cannot see on CT. This is only visible on MRI. We will discuss it with MRI. Okay. Now what happens is, gradually if the ischemia proceeds further, you start developing endothelial damage. The capillary endothelium will start getting damaged. If the ischemia persists, the capillary endothelial cells start to die. If the capillary endothelial cells die, the capillaries become leaky and you start developing vasogenic edema. While the neuronal swelling is called as, in radiology we call it cytotoxic, cell dead edema. Now CT scan cannot show you cytotoxic edema, but it can show you vasogenic edema. When there is fluid accumulating from leaking of capillaries, so when the water is leaking into the brain parenchyma, that parenchyma will become more dark. So this vasogenic edema is seen after 6 to 24 hours. This vasogenic edema takes 6 to 24 hours to develop. And this is visible on NCCT. Okay. Are you clear? So this is visible on NCCT. Are you clear, beta? So should I repeat? I'm repeating for all of you, beta, again. My question is these. These are tough questions. Don't panic. In a patient with stroke, what will you do first? What investigation will you do in a patient with stroke? Investigation of choice is NCCT. Why? Our goal is to rule out hemorrhage. Because in the first few hours, CT scan can be normal because edema takes some hours to develop. CT scan can see the infarct only after 6 hours. In some people, it takes even 24 hours. So why do we do a CT in a patient with stroke? To rule out hemorrhage. To rule out hemorrhage. Okay, not to detect infarct. CT scan can be normal in first 24 hours of infarction. It is possible that a patient with brain infarct can have a normal CT in the first 24 hours. Now, एक बच्चा कह रहा है AMS के sir, why we have cytotoxic edema? Let's try to understand. Cyto मतलब neuron का cell. Cyto is cell. Toxic means dead. So when the neuron dies because of ischemia, sodium potassium ATPase is not working, so neurons become swollen. That is, swelling is edema. So cytotoxic edema can only be seen in a special type of MRI. I will talk about it later. CT can show us infarct, but later. And on a CT, I have shown you the difference between a large vessel infarct and a lacunar infarct. Okay. Now I will give you a tough question. I am giving you a tough question. Okay. Okay. Henry Patel is saying, sir, if we wait, we will worsen the problem. Yes. And I will cover this again when I tell you MRI. Don't worry. We have to diagnose infarct early because time is brain. We have to think about giving thrombolytic therapies. That we will talk when I look at MRI. Now I want all of you to look at this patient. This patient comes to emergency and NCCT brain is shown to you in emergency. Anybody can tell me where is the abnormality. Now please see with me. This area is abnormal. What is this? This is the middle cerebral artery of the patient. But do you agree this middle cerebral artery is appearing very dense? It is more dense than the other side. So middle cerebral artery is hyperdense. In this patient, his middle cerebral artery is hyperdense. Now I see one bacha saying, sir, nahi bache, aksa na kar, please listen to me. दोबारा सुनो बेटा, आप दोबारा सुनो. आप समझ नहीं रहे हैं, आप याद कर रहे हैं, तो इसलिए मुश्किल हो रही है. दोबारा से सुनते हैं. Listen to me again, everybody. See, if there is ATP less, if there is ischemia, all cells in that area will die. But first neuron will die. Capillary endothelium is more resilient. It will die later. इसलिए मैंने बोला, because of ischemia, first the neuron cell will die. It will become swollen. Only visible on special type of MRI. Then endothelial cells will also die because they are also cell. They need oxygen. And then you have vasogenic edema developing. आप समझा? Are you clear? Okay. Are you clear or not? Second question is that infarct, if it is due to occlusion of a large vessel, Lisa AV has asked, then it is going to be a wedge-shaped infarct. But if it is a branch vessel that is occluded, you will see a small infarct like this, which is called as the lacunar infarction. Lacunar infarction is defined as less than 1.5 centimeter infarct. Okay. NCCT is non-contrast CT. I will explain it after this. I will again explain it to you. Okay, what is contrast and what is non-contrast CT. Have patience. Okay. Now tell me. In this particular CT, we saw the MCA is hyperdense. Now, when does blood become more dense? When it clots. I have already explained to you, when the blood clots, RBCs come close to each other, the globulin comes close to each other, becomes hyperdense. So this is earliest CT visible sign of infarction, of acute infarction. Okay, so what do you see here? You are able to see hypertense. So Joel Lewis is saying कि hemorrhage तो hypertense था, तो infarct क्यों hypertense है? अभी समझाया ना मैंने. बेटा सोचो. Joel Lewis, I am repeating for you. Infarct is dark because it is having edema here. The fluid from the capillaries is leaking. So if the brain parenchyma has more water, water is more dark as compared to brain parenchyma, it becomes hypotense. Okay, Joel? Okay. Now we have some more questions which I will answer with you gradually, but tell me, what is the earliest CT visible sign of infarction? The answer is dense MCA sign. If on CT your middle cerebral artery appears dense, you will say dense MCA sign. That is a sign that you are looking at hyperacute infarction. We are able to pick it up early if I see dense MCA sign. Not always you will see it, but if you see it, it tells you that there is a thrombus in the middle cerebral artery. Okay, now let's go further. My question to you is, I have only told you 3 things so far. The chapter of brain infarct in radiology is not over. I will repeat it when I show you MRI. I teach you diffusion weighted MRI. I will repeat it for you. Okay. But so far I have shown you infarction, a lacunar infarct. I have also shown you dense MCA sign. 3 visuals. Okay. Now my question to you is this. Can you have a venous infarct? Okay. Can you have a venous infarct? The answer is yes. We can have venous infarct if we have cerebral venous thrombosis. Okay. Now one bacha is saying, sir, the anteriorly dark structure that you see here is that is definitely a frontal sinus. That is correct, beta. Very good. Okay. Now tell me, you can have a venous infarct in brain if you have cerebral venous thrombosis. In which kind of patients you can have cerebral venous thrombosis? Cerebral venous thrombosis can happen if you have hypercoagulable state. Can you name any hypercoagulable state that you are aware of from your pathology knowledge? Can you name any hypercoagulable state with your pathology knowledge? That is, any one of you? Pregnancy, oral contraceptives, dehydration, and you can also, they can say protein C, protein S deficiency. Okay. But the most important question here is going to be on pregnancy, oral contraceptives typically. Okay. So in people who are having a hypercoagulable state, you can have thrombosis of the cerebral veins. Okay. Now what will happen? Let us try to understand, and I want your full focus. Yes, definitely, even in nephrotic syndrome, etc. also you can have it. That's correct. Good point. Now tell me, bacha, if this is your artery, arterioles, capillaries, venules, veins. Now suppose you have cerebral venous thrombosis and you have obstruction to the vein because of the thrombus, venous thrombosis is there. Okay. Then what will happen to the capillaries? Anybody? If you have venous thrombosis, what will happen to your capillaries? The capillaries will start to leak fluid. If there is venous fluid, the capillaries will start to leak fluid and you will develop edema. Okay, and I know many of you are saying many other hypercoagulable state, but we have to look at the common problems: oral contraceptive intake, pregnancy, that is mostly asked, or child with nephrotic syndrome, they can say, or a patient with recurrent diarrhea and dehydration, they can say. They will try to give you a common question here. So if the venous thrombosis is there, the capillaries start to leak. Okay, so now tell me, I want all of your attention. If around the capillary you have edema, what will be affected? The tissue oxygenation will be affected. If there is edema, the oxygen cannot diffuse into the tissue and the tissue will start to die, which is called as infarction. So in venous infarct, the capillaries start to leak fluid, there is edema, then it leads to infarction because tissue oxygenation cannot happen because capillaries are now having some fluid around them. Infarction. Okay. Now anybody tell me, artery is patent. So the tissue is infarcted, but the artery is sending into the infarcted tissue. So in the infarct, what will happen to the capillaries? In the infarcted tissue, what will happen to the capillaries? Capillaries will become fragile. So when the high pressure arterial blood is going into the capillaries start to rupture. Capillaries start to rupture and that leads to areas of hemorrhage. Okay, that leads to areas of hemorrhage. So now can anybody tell me, did you read this in pathology that venous infarcts in the brain will be red infarcts? Venous infarcts are hemorrhagic. It is different from arterial infarct because the artery is patent. So high pressure blood is constantly flowing into the infarcted tissue. The capillaries start to rupture, leading to areas of hemorrhages. Are you clear, beta? Are you able to understand my point? Is that clear? That yes. So if you notice, what I am trying to do is I am trying to give you the concept. Then I will take you to radiology. But first you need to understand that there can be cerebral venous thrombosis. Most people forget the veins. So I will tell you that in brain there are veins. These are your veins in the brain. And please see, you have superficial veins, deep venous system. I will label the veins, please see with me. This large vein in the midline is superior sagittal sinus. Superior sagittal sinus. It is in the midline. It goes from front to back like this. A large superficial vein draining into the superior sagittal sinus is called as vein of Trollard. Vein of Trollard. So if they ask you vein of Trollard drains into, it drains into superior sagittal sinus. Okay. This is your transverse sinus, which continues as sigmoid sinus, which drains into jugular vein, internal jugular vein. So transverse sinus, sigmoid sinus, jugular vein. A superficial vein draining into transverse sinus is called as vein of Labbé. Superficial vein draining into transverse sinus is called as vein of Labbé. And also remember, sigmoid sinus is communicating with cavernous sinus through the petrosal sinuses. Cavernous sinus and sigmoid sinus are connected through the petrosal sinus. Let us look at the deep system now. The veins draining the thalamus and the basal ganglia. The veins draining the thalamus and the basal ganglia will be called as thalamostriate veins. These thalamostriate veins will join to form internal cerebral veins. So on both sides there will be thalamostriate veins draining into internal cerebral veins. Two internal cerebral veins will join to form the great vein of Galen. which will join by inferior sagittal sinus to form the straight sinus. Are you clear? Are you able to see this? So I was just revising it because otherwise these names might look strange to you. So I was just trying to make sure that we have some remembrance that you have venous, deep and superficial venous system in the brain, which can get thrombosed in hypercoagulable state. Okay. Now my question to you is this. Suppose I do a CT scan at this level. Suppose I take a CT cut at this level, at the section that I am drawing. You will see the brain midline and you will see the superior sagittal sinus like this. So cerebral venous sinuses are triangular in shape. They are not like arteries. Arteries are round. Venous sinuses, because they are in the dura, they are triangular in shape. Okay. So when you do a CT scan, this is anterior, this is posterior. Posteriorly in the midline, the superior sagittal sinus is there. Suppose it is thrombosed. Suppose there is a thrombus here. What will happen? Suppose there is a thrombus here. This area will become hyperdense, more white, and it will look like a triangle. It will look like a delta. That is why we call it delta sign of cerebral venous thrombosis. Cerebral venous sinuses are triangular in shape. So when they get thrombosed, okay, Simran, Shivam, I'm trying to repeat, try to understand. ये जो venous sinuses हैं, these are triangular in shape. So when they get thrombosed in a cross section, they look like a dense triangle. Okay? Clear? Now everybody try to understand. This is just the theory. I have not taught you radiology. I am only revising the anatomy and pathology. I will now show you radiology, beta. Everybody see. Suppose I tell you this is NCCT in a woman on oral contraceptives. What do you think is happening? Tell me, beta. Woman on oral contraceptive, NCCT is shown to you. Everybody now tell me, beta. Look at it. Now focus, focus, focus. Wake up, wake up. It is morning. Good morning. Tell me now. Can you now see, everybody, that this area is a hyperdense triangle in the midline posteriorly? What is it? Tell me the name of the sign. This is delta sign. What is your diagnosis? Cerebral venous thrombosis. So again I am saying, okay, this is not delta airline, this is delta sign, and I am again repeating, beta. NCCT matlab non-contrast CT. That means we are doing a CT without giving any injection of dye. If I say CCT, that means I have given IV injection of dye. So what is the NCCT sign of cerebral venous thrombosis? Delta sign. Delta sign. Any one of you can answer, beta. Any one of you can answer, beta. Okay, I am asking you a question. ठीक है, सोच के बताना. Did you also hear in ENT class delta sign? Let's connect the dots. ENT में सीखा था delta. CSOM. If you have an ear infection, it goes into the venous sinuses, cause thrombosis, and you can see a delta sign if there is a cerebral venous thrombosis complicating middle ear infection. Okay, so are you clear now? Delta sign. Okay, second question now. Very tough, beta, very tough. Suppose I do a contrast enhanced CT in this patient. Suppose I give intravenous dye. Now, if I give intravenous dye, IV contrast, what will happen, beta? Tell me. Okay. So, if I give IV dye, what will happen? Tell me, think of it. Now, the dye will go into all the blood vessels. It will go into the venous sinuses. My question to you is, if the sinus is thrombosed, can the dye enter the sinus? No, it cannot, because the sinus is thrombosed. So what will happen? Because the sinus is thrombosed, it will remain dark. It will have filling defect. All other vessels will be taking up the dye, but the sinus will be empty because it cannot take up the dye. I will explain it to you with an image again. Everybody focus on the class. Listen to me again. Look at this area now. Suppose I tell you that this is a contrast enhanced CT. Now, what do you appreciate? If this is a contrast CT, the veins should be white because they should be full of dye. In this particular patient, it is still dark. It is empty. This is called as empty delta sign. Okay, so I'm again repeating because I know some bachas are finding it tough. I'm repeating it for you, beta. See, radiology is complicated, but once we get a grip of it, that I am going from anatomy pathology onward into the radiology. Now we can connect it. That venous thrombosis in brain is possible. It happens, especially in pregnant ladies, ladies on oral contraceptives. Even after recent COVID vaccination, also it is one of the risk factors for CVT. On NCCT, you will have delta sign. On CCT, you will have empty delta sign. Don't get confused. Okay. Now, Vishnu is saying any venous thrombosis will have delta sign. No, beta. Cerebral venous thrombosis will have delta sign. Other venous thrombosis, leg veins, I will tell you later on when I tell you Doppler of the leg veins, I will teach you, beta. Don't worry. Okay. Now, one bacha is saying, how will we know is it NCCT, CCT? It will be written in the question. It will be written in the question, my dear children. Now tell me, I am again revising. The large sinus that you see here, superior sagittal sinus. A big vein draining into it, vein of Trollard. Transverse sinus, sigmoid sinus, jugular vein. Which vein is draining into the transverse sinus? Vein of Labe. Petrosal sinus is connecting the cavernous sinus to the sigmoid sinus. Thalamostriate veins draining into internal cerebral veins. Two internal cerebral veins will join to form vein of Galen. Vein of Galen will join the inferior sagittal sinus to form the straight sinus. Clear? Are you able to understand? Okay. Are you clear? Okay. Now let's see and answer further. Now let's try to go deeper into it. Let me just show you more concept here. Because now you have seen the arterial and the venous thrombus. I just wanted to clarify some things. Try to give me 1 second and I will make one more concept for you. Please see with me. What blood vessel is seen in this image? This is your aorta. Okay, and I am telling you this is a CT angiogram to look at the aorta. Okay, my question to you is this. Any one of you can answer my question. Tell me, when we do CT angiogram, we are giving intravenous dye or intra-arterial dye? Anybody can answer now. Anybody can answer? That CT angiogram will be seen after IV dye injection or intra-arterial dye? Anybody? Can you answer? The answer is intravenous. Now I hope you are able to understand कि bhai, when I told you cerebral aneurysm, investigation of choice is CT angiogram because it is done with a simple IV injection. But when we have to do more accurate delineation, we have to do a treatment. We go for DSA, which is the gold standard. DSA is done after arterial puncture, CT angiogram, IV contrast. Now some children are getting confused. Sir, IV se artery mein kaise aa gaya? I will explain to you. Whenever we give intravenous dye, it goes into your arm vein, it goes into the subclavian, goes into the superior vena cava, goes into the right atrium, right ventricle. From the right ventricle, it goes into the pulmonary artery. From the pulmonary artery, the dye goes into the lungs, into the pulmonary veins. From the pulmonary veins, left atrium. From the left atrium, left ventricle. From the left ventricle, aorta. From the aorta, it will ultimately go into your tissues. Okay? Are you clear? Are you able to understand my point or not? Should I repeat? So how the dye is traveling is intravenous dye goes into your vena cavas, into right atrium, right ventricle, pulmonary artery, pulmonary vein, left atrium, left ventricle, aorta tissue. Now try to understand. Suppose after IV injection, I start my CT scan within seconds to catch the dye in pulmonary artery. This is called as CT pulmonary angiogram. Okay. Now suppose I delay the CT scan a few more seconds, the dye will be more seen in the aorta, so this will become CT angiogram for the aorta. And if I delay the CT further, dye will have gone into the tissue. Dye will go into the tissue. Which tissues? Now suppose you have some inflammation or you have a tumor. Now I want all of you to focus. Don't look at the time. We are not time bound workers. We are doctors. We are not looking at time. Please tell me now. If you have inflammation, you will have hyperemia, increased blood flow. If you have tumor, neovascularization, increased blood flow. So the dye will go into inflamed tissue, tumor. This part is called as CCT. Now many children, they get confused, and this is a CT angiogram is also done with IV injection. CCT also IV injection. What is the difference? Difference is in timing. If after rapid bolus of dye, a quick CT is done, we catch the dye in the blood vessels, this is CT angiogram. If we delay it for a minute or so to see it in the tissue, to find a tumor or inflammation, that is CCT. Okay, clear? Able to get all the children now who were saying NCCT, CCT, little satisfied? CCT is done after IV injection of dye. I will tell you what dye also, don't worry. Okay. My question is this. My question is this particular image. I want all the children who are in the class right now, to tell me what body part is this? What body part is this? Is this brain? Is this your brain or no? No, this is not brain. This is thorax. This is thorax. And what part of thorax do you see here? I will help you. This is your ascending aorta. Everybody listen to me. Better don't panic. I will explain. Ascending aorta, descending aorta. Ascending aorta, descending aorta. What is this? Main pulmonary artery. Ascending aorta, descending aorta, main pulmonary artery. Now, all of you now, without any bias, please tell me, where is the dye present? Is it in the pulmonary artery more or is it in the aorta more? Dye is more in the pulmonary artery because this is a CT pulmonary angiogram. Because whenever we give IV dye, it first goes into the pulmonary artery, then it goes into the aorta. Are you clear? This is CT pulmonary angiogram. Okay? Everybody understands? Okay. Now tell me, beta. If the dye is in the pulmonary artery, why is there a saddle shaped defect? Why this area is appearing dark? Why do we have a saddle shaped filling defect here? What is this? This is pulmonary embolism. Okay, this is pulmonary embolism. Are you clear, beta? Aap samajh aaya? Very important visual, multiple times asked in your exams. This is pulmonary embolism. Okay, how will they frame the question? They will say this is a bedridden patient with acute onset breathlessness, comes to the emergency. A bedridden patient has acute breathlessness, comes to the emergency. My question to all of you is, why bedridden is important? Why bedridden is important? Tell me. Because leg vein stasis can lead to thrombus. Remember Warco triad, stasis, endothelial injury, hypercoagulable state are three causes of thrombosis. So bedridden patient will have stasis. stasis, and that thrombus, if it breaks, can go into the pulmonary circulation. Clear? And even in long transcontinental flights, they can write it as a question. That patient was taking a long flight from maybe from Australia to America or India to America, and then he developed. It is possible. Long transcontinental flights also, you might have seen in long flights, they keep telling you to keep moving your feet, and all that. It is one of the risk factors. What is the investigation of choice for pulmonary embolism? Anybody wants to answer this question? What is the investigation of choice for pulmonary embolism? The answer is CT pulmonary angiogram. Investigation of choice for pulmonary embolism is CT pulmonary angiogram. But suppose they ask you, what is the screening investigation to be done? Okay, let's see how many of you can answer this. Suppose bedridden means, Prince, bedridden matlab ki somebody has some fracture, hip fracture, chronic illness, not walking too much, mostly on the bed. Okay, now tell me, screening pulmonary embolism. Tell me, screening for pulmonary embolism is done with a test called as D-dimer assay. Screening is done with D-dimer, investigation of choice, CT pulmonary angiogram. Okay, my question to you are these. What will you find on chest X-ray? If you do a chest X-ray in a patient with pulmonary embolism, what will be the finding? Chest X-ray in pulmonary embolism is usually normal. Usually the chest X-ray in a patient with pulmonary embolism will be normal. But some patients can show you a peripheral wedge-shaped infarct. Some patients can show you a peripheral wedge-shaped infarct on a chest X-ray. This finding was described by Dr. Hampton. So to give him respect, we say Hampton's hump. Okay, peripheral wedge-shaped infarct is called as Hampton's hump. Rarely seen. Mostly chest X-ray in pulmonary embolism will be normal, but you can see some patients Hampton's hump. Some patients on chest X-ray will have focal oligemia. That means on chest X-ray, when I will teach you chest X-ray, I promise you I will spend a lot of time on chest X-ray. In chest X-ray, in the lungs, you will see vascular markings. You will see blood vessel marking. If you find an area where vessel marking is not there, vessels are not seen, focal oligemia, it is called as Westermarck sign. It is called as Westermarck sign. Chandresh and Shubham are rightly telling this, and I am repeating again. So you've seen 5 questions. Number 1 is this. In the exam, they will give you a picture like this. Say, identify what has happened in this patient. This is pulmonary embolism. Investigation of choice, CT pulmonary angiogram. Screening, D-dimer. Chest X-ray, most commonly normal. Wedge-shaped opacity, peripherally placed, Hampton's hump. Focal area of reduced vascular markings, Westermarck sign. Okay, नितिन चौहान is saying curly, बेटा curly नहीं, curly line heart failure में आएगी, मैं बाद में पढ़ाऊंगा, don't worry, I will teach. Okay, curly line is not seen in pulmonary embolism, it is seen in heart failure. नितिन चौहान, okay, गलती नहीं करना बेटा. Okay, I will explain later. Okay, focal oligemia. Focal मतलब a aksa nayab. Focal means in one particular area reduced blood vessel markings. Normally in lungs you should see some vessel marking. Small area devoid of vascular markings. In a bedridden ICU patient, you should always think of Westermarck sign. Okay. Now third sign is, if there is a embolus, usually it will cause dilatation of right descending pulmonary artery. That is called as Palas sign. Okay, Chandresh and Sangeeta, happy? So if you see a dilated right descending pulmonary artery, that is called as Palas sign. That is called as Palas sign. Are you able to answer this, beta? Everybody happy? Okay. Now, अमृता सिंह के सर हम CCT में इंट्रा आर्टीरियल डाई क्यों नहीं दे देते? बच्चे कोशिश करके देखना, ट्राई इट एट होम. IV is very non-invasive kind of a thing. Intra-arterial is a invasive procedure. Okay. Now, Arushi Gupta is saying, why the Hampton hump is in the lower part of the lung? Arushi, try and tell me. Although I don't know if you are good at this or not, but Arushi Gupta, one question for you, tell me now. Blood flow in the lungs is more in the lower part of the lung. Tell me why? Because of the gravity. We are erect animals. Lower lobes have more blood flow, that is physiological. So embolus is coming via the hematogenous route. It is coming via the blood. So it is likely it will go into the lower lobes. Any pathology which is hematogenous in the lung, it will be going into the lower lobe more. Do you agree or not? Because lower lobes have more blood flow. I'm sure you have read this. Okay. Okay. Now, why isn't embolus hyperdense? Okay. Now, Shreya, I am telling you, embolus will be hyperdense, Shreya, lekin NCCT pe. This is not NCCT. As compared to the IV dye is very white, dye is radiopaque. As compared to the intravenous dye, it is looking darker. It is looking like a filling defect. But had we done a non-contrast image, it would be hyperdense. Are you clear? NCCT or CCT mein, that is the difference. Okay, bache? Okay. So what are the three signs of X-ray signs of pulmonary embolism? Hampton's hump, Westermarck sign, Palas sign. Okay, bache? All three are chest X-ray sign. All three are chest X-ray sign. Okay, bache, now let's move forward now. Okay. Now allow me to move forward and just do one or two more images. I have just, I think one or two more images on the CT scan. I want to finish CT today so that in the next class we can start fresh with MRI. Okay. Anybody can tell me if this is your ascending aorta and this is your descending aorta. This is your main pulmonary artery. Okay. Can anybody tell me where is the problem? Where is the problem? Okay. So Nidhi and Suryavanshi, I am repeating for you pehla. देखो pulmonary embolism में artery जो right lower lobe की artery है, it gets embolus typically goes to the lower lobe artery, typically on the right side, and it causes dilatation of the shadow that we see on the X-ray. So dilated right descending pulmonary artery on X-ray is called as Palas sign. एक बच्चा पूछ रहा है सर फिर ओलिगीमिया कैसे होगा? उसके डिस्टल होगा ना, सेंटर में एम्बोलस है तो डिस्टल टू इट यू विल हैव ओलिगीमिया. ओके. नाउ इन दिस पेशेंट द असेंडिंग एओर्टा इज हैविंग टू ल्यूमन्स. कैन यू सी डबल ल्यूमन? यस, दिस इज aortic dissection. This is aortic dissection. Are you clear, beta? Now quickly answer my question. Two questions for you, beta. Two questions for you. Okay. In which kind of patients aortic dissection happens? Now either the blood vessel wall is easily breakable or you are having high blood pressure. So hypertensive patients can have it, or Marfan syndrome. Okay. Or Marfan syndrome is also one of the causes. Okay, what is the investigation of choice for suspected aortic dissection? Now always remember, if they say aortic dissection or if they ask aortic aneurysm or if they ask aortic injury, investigation of choice is same, it is CT angiogram. Okay, 3 questions for you. I am repeating now. Aortic dissection, aortic aneurysm, aortic injury. Investigation of choice, CT angiogram. However, if they say aortic dissection suspected in a hemodynamically unstable patient, if they say aortic dissection in a hemodynamically unstable patient, then you cannot send a patient for a CT scan. You have to do a bedside transesophageal echocardiogram. Okay. Okay, Sakshi, I think I will repeat it for you. I am again repeating. Are you able to see this much? तो समझ आ गया ना, इस ascending aorta में 2 ल्यूमन है, बीच में एक intima है और blood intimal tear होने के कारण the blood has gone into the false lumen. There are double barrel kind of aorta you can see here. This is aortic dissection, life threatening condition. Investigation of choice, CT angiogram. But remember, if the patient is not having vital stable, then you will do transesophageal echocardiogram. Okay, not fast beta, not fast निधि, नो फास्ट हम ट्रॉमा में करेंगे, एब्डोमिनल ट्रॉमा में. ये aortic injury बोला मैंने, CT angiogram मार्क करना है. aortic injury, aortic aneurysm. Okay, now we will talk about fast in my next class, don't worry. Subsequent classes में I'll talk about everything. My question to you is this. I will show you, but I will show you sadhana and everything. I show you. Aortic dissection. Okay, what is happening in aortic dissection? Let's try to understand. Suppose this is your heart, this is left ventricle, this is aortic valve, ascending aorta, arch of aorta, descending aorta. Okay. Now suppose you have hypertension or the patient is having Marfan syndrome. So what happens is, in these people, the blood enters through a intimal tear. Always remember, blood vessels have 3 layers: intima, media, adventitia. So what will happen is, in aortic dissection, you develop a tear in the intima through which the blood enters between the intima and adventitia. The blood starts to collect in the media between the adventitia and the intima. The blood is collecting. This becomes your false lumen. This is your true lumen. Okay, you can see it here also. The part which is taking up the dye, that is your true lumen. The part which is not enhancing properly, it is not taking up the dye properly, is your false lumen. Okay. Okay, now my question to you is, aortic dissection, if it involves ascending aorta or arch of aorta, descending aorta involved or not involved does not matter, you will call it as Stanford type A dissection. If ascending aorta and arch are normal, only descending aorta is having dissection. Only descending aorta is having dissection, you will call it Stanford type B. Are you able to understand? Are you able to understand this? Okay. So again I see one bacha saying CT angiogram. What is the difference? Both of them are using IV dye, but in CT angiogram we are using a rapid bolus IV injection with a very fast CT technique. CECT we are delaying it to see the tissue enhancement patterns. Again I am repeating, if ascending aorta and arch is dissected, Descending aorta, normal or abnormal, does not matter. Call it Stanford type A. Okay. Now tell me. Everybody now look at this image and tell me now. Look at this image and tell me what type of dissection is this patient having? What type of dissection do you think this patient is having? Tell me, beta. This is type A dissection. Stanford type A dissection. Why? Why it is Stanford type A? Because the ascending aorta is dissected. It has to be type A. Okay, beta. Now tell me. I'm sure many of you can answer this question. Now, what is the risk? Okay, I want all of you. Just listen to me. Just listen to me right now. Even if you don't write, it is okay. Because the answer is only one word, but listen to me. Suppose you have dissection in the ascending aorta. The blood enters through the intimal tear and then blood also ruptures the adventitia. If the blood ruptures the adventitia, then what will happen? The blood will come out and the pericardium is fused at the root of aorta. Parietal pericardium is fused at the root of aorta. The blood will start accumulating around the heart in the pericardial space. What is the risk? It can lead to cardiac tamponade. Stanford type A dissection, because it is near the heart, if it ruptures, it will lead to cardiac tamponade. Also, second thing to remember is, this is where I can see many of you are able to answer. I'm so proud of all of you. Actually, radiology is very great branch. Actually, you will see so many other pathologies over my classes, and that is why I wanted to divide it, because if I do chest, X-ray, brain, everything together, sometimes the children get confused. So I wanted to go step by step, because I want to make sure that 10 out of 10, all 10 questions you should be able to do. This is where your coronary arteries are originating. Now suppose you have dissection near the coronary origin, what will happen? You will develop acute MI. Are you now able to understand why a patient with aortic dissection sometimes come with acute chest pain, acute MI, aortic dissection? It is possible that patient can come with MI, or the patient can lead to problem in the valve, aortic valve, leading to valvular insufficiency and heart failure. Entire moral of the story is, aortic dissection, if it is Stanford type A, it is potentially life-threatening because it can lead to cardiac complications like MI, cardiac tamponade, heart failure. So it should be managed urgently, surgically. Urgent surgical intervention is required. Otherwise, the patient will die. While Stanford type B can be managed medically, because the dissection is away from the heart. Away from the heart, you can manage it medically. Are you able to understand? Okay. Now see, again, I see some bachas getting confused. Sir, aortic dissection में MI कैसे हो सकता है? कैसे हो सकता है? Because if there is a dissection, Nidhi and all bachas who are asking, Gurleen, Abhinya and Shekhar, Gurleen, no, please see bache. If there is aortic dissection, the blood is going into a false lumen. This is not a true lumen. The blood flow will be sluggish, stasis, thrombus formation. It will have thrombus formation ultimately, and if the coronary is originating from this area, it will get blocked and you will have MI. Are you able to understand this? So I am repeating again. In aortic dissection, if ascending aorta is involved, Dr. Sahab, it is a life-threatening situation. You cannot say कि कल बताऊंगा, कल आएगा ही नहीं. Okay, urgent surgical intervention. Are you now able to understand? Okay. Now Sneha is saying, sir, cardiac tamponade क्यों हो रहा है? Now you understand now. Before my class, you were not asking why at all. Now suddenly in my class, all whys are happening because parietal pericardium inserts at the root of the aorta. So if the proximal part of the aorta ruptures, the blood goes into the pericardium, and rapidly accumulating blood will lead to tamponade. Okay. Okay. Everybody is clear. So we have so far seen two questions. These are two questions very often asked in NEET PG and also in INI set also. Aortic dissection, pulmonary embolism. Two very important CT images. You should be able to do them 100% of the times. Okay. Now let's look at some advances, some small advances on CT technology. Okay, I will show you some small things, not too difficult, very simple ones. One is this. Today what is happening is, I want all of you to listen to me. It's morning only, you are all fresh. It's good morning everybody. Okay, now tell me. I want all of you to have 1 second of patience. Try and see. Today it is possible to do 3D reconstruction using the CT scan data. This is a 3D CT. This is a 3D CT. Hey, what is HT? HT was hypertension. Hypertension. Okay. Now tell me, everybody tell me. Look, listen to me. Meri baat sunenge bache. Listen to me. Now, do you remember in the beginning of the class I told you, CT scan has 3D capabilities because we are having the machine rotating around the patient. So that means you can create 3D images. So this is how a CT image in 3D looks like. Now, can you imagine? Just forget that you have an exam or something. Imagine the power that you have as a doctor. Today you can visualize complex pelvic fractures, acetabular fractures, Le Fort fractures, craniofacial fractures, all with 3D CT. Understand? Earlier all we were guessing with the pelvic X-ray, we could not see much. With 3D CT, we are able to rotate it and see the 3D anatomy, and complex fractures we can assess by 3D technology. Okay? Are you able to understand this? Okay. One more image. Now with CT evolving further, we have now the capability to do a cardiac CT. This is how a cardiac CT looks like. These are your coronary arteries. These are your coronary arteries. Now the reason is, have you ever heard of, okay, just a few more lines, okay, have patience. Have you ever heard of the term multi-slice CT, or they will say multi-detector CT in your hospital, MDCT? Or you might have heard of somebody saying 64 slice CT, 128 slice CT, 256 slice CT, like this. Have you heard of this in your hospital? Now today the CT machines are so fast that they can do multiple sections in single rotation. Okay. Amrish is asking what was TEE. TEE was transesophageal echocardiogram. Okay. Now please see. Listen to me. So far CT technology, whenever we were rotating around the patient, we were taking one section of the body. But now with multi-slice CT, in one rotation we can take multiple sections. Suppose you have 64 slice CT, you can take 64 sections, one rotation. So these are very fast scanners. Now heartbeat is 72 beats per minute. So one beat is taking 0.8 second. So if my CT machine is rotating around the patient faster than the second, faster than the heart rate, I can also image the heart. So today, because heart is constantly moving, are you able to understand? To do a CT scan, the patient should not move, but heart is moving. So you can only do a cardiac CT if your CT machine is scanning faster than the heartbeat. So this is all possible today. Today you have even cardiac CT available. Just 2 lines about it. Okay, just 2 lines about it. Cardiac CT is used to estimate coronary calcium score, also called as a Gadsden score. Okay, cardiac CT is called as coronary calcium, can be used to estimate the amount of calcium in the coronary artery, which is called as coronary calcium score or a Gadsden score. So if you have calcium in the coronary arteries, it can help you to screen for coronary artery disease. That means if you have a person who comes to you, you do a cardiac CT in health checkup. If the coronary have calcium, that means there is atherosclerosis, the patient needs further evaluation. This is one common indication of doing a cardiac CT. Second indication is cardiac CT can find if there is any anomalous coronary origin. In embryology, they will tell you that coronary arteries are arising from those sinus of Valsalva area, but sometimes it may arise from pulmonary artery. Sometimes the coronary might have an anomalous origin that can be diagnosed by a cardiac CT. Just 2 lines about cardiac CT. I am again repeating. Just 2 lines about cardiac CT. It is not better than catheter angiogram that is done in MI patients, because that is going to treat also. Here the goal is only screening. Screening is done in high risk normal people. You remember? Do you understand बच्चा जो पूछा था Amarthian? Are you clear? Screening is done in high risk people who have a high chance of having the disease. So coronary calcium scoring with cardiac CT is a screening technique. Aryan Malhotra is saying, is it useful in Kawasaki disease? Answer is yes. It is a very good question. I appreciate you. In Kawasaki disease, you can have coronary artery aneurysms that can also be seen on cardiac CT. I have also diagnosed myself also. So Kawasaki disease can have coronary artery aneurysms. We can see them on cardiac CT. Okay. Now, what is this? Is this also CT scan? I told you I will show you some advances. Today we have a new CT technology which is called as dual source CT. Dual source CT, also called as spectral CT. Okay, also called as spectral CT. It has the capability to identify crystal deposit diseases. Can you name some crystal disease? Gout. And it can also identify the urinary stones. It can characterize the urinary stones. I will explain it to you. Urinary stones can have uric acid or can have calcium oxalate. I am sure by now most of you are aware of that uric acid stones are to be managed medically. Uric acid stones have medical management. But today the CT can identify and tell you that you have a uric acid stone. With the technology called as dual source CT, we can characterize that you have uric acid stone or you have a calcium stone. We can identify gout. The image that I am showing you here is a patient with gout, where these green colored deposits are all uric acid deposits. Okay. So they might ask you in the exam. I will teach you gout X-ray later on with the bone X-rays. But I want you to understand, if they say what new technology is now used in gout, what new technology is now used in gout? The answer is dual source CT or spectral CT. Okay. And for your comfort, the image book I have also uploaded as a PDF in your notes and test section of this course also. So don't worry. And finally, the final part of the class. What contrast material do we use in a CECT? What dye do we use in a CT scan? I have told you multiple times that we are using a CT scan, we are using a dye. But what dye? We are using a dye called as iodinated contrast. Okay. So Unan Pawan Kumar is saying, sir, blood clot ka density time ke saath change hoga? Yes. So blood clot is hyperdense, but when the clot will liquefy with time over a period of 1 month, it will become like water. Okay. So final topic. What dye do we use in CT scan? Iodinated dye. Why? Because iodine is radio opaque. Iodine is a radio opaque substance. Can you name some types of iodinated contrast? It can be divided into ionic, non-ionic. Okay, I am again repeating. In CT scan, we use X-rays, so we need to use a dye which is radio opaque. So we use iodinated contrast which is radio opaque. Iodine is a radio opaque substance. Hence it is used for IVP, HSG, CECT, angiography, any investigation which uses X-rays uses iodinated dye. Okay, so iodinated dyes are two types, ionic, non-ionic. I will tell you what is preferred. Ionic dyes are further divided into monomer, dimer. Non-ionic dyes, monomers, dimers. Okay, monomer, dimer. Ionic monomer are the oldest dye. These are the dyes which were earlier used. Urographin, gastrographin. Osmolarity high, 1400 to 1600 milliosmol. Urographin, gastrographin are ionic monomers which have more side effects because of high osmolarity. Okay. Now, my question to you is this. Anybody can answer. So they are not preferred now because they have more side effects. So we don't use them in CT scan. But can you tell me two indications of gastrographin? Two surgery MCQs where gastrographin is used. Can you give me two surgery MCQs where the answer is gastrographin? Anybody? Koi bhi? So one is, I will tell you bache the complications etc. Don't worry. Bowel perforation. Gastrographin study is used in suspected bowel perforation. Secondly, it is used in a patient with cystic fibrosis if you suspect the infant has meconium ileus. In meconium ileus, you will read in surgery, we give a gastrographin enema. In meconium ileus, we give a gastrographin enema. Can you understand why? Because this enema will not only diagnose, it will also treat the patient because the thick meconium, this happens in cystic fibrosis infants, and gastrographin is hyperosmolar, it attracts the water towards it and it dislodges the plug and the patient is treated. Okay, I am again repeating. Name two MCQs in which we will mark gastrographin as the answer. Bowel perforation, gastrographin study. Meconium ileus, we will use gastrographin enema, both diagnostic and therapeutic. Both diagnostic and therapeutic. Are you clear, bache? Okay. Ionic dimer, the example is only one, ioxaglate. Ioxaglate. Not many questions will be formed here. Osmolarity 600 to 800 milliosmol. Okay, ionic dimer, ioxaglate, osmolarity 600 to 800 milliosmol. But what is commonly used is in CT scan is non-ionic monomer, iohexol, ioversol, iopamidol. By the time you write down, I will answer a question by Nabeen Saha. And I think one bacha ki bowel perforation mein kyun? See, in bowel perforation, if you are suspecting bowel perforation, you cannot use barium. Barium is not soluble in water. So if you give barium to a patient to find out where is the leak, barium will go into the peritoneum, but it cannot be absorbed because it is not soluble in water. It will cause chemical peritonitis. But gastrographin is water soluble. So it can be easily used for bowel perforation because it is radiopaque and water soluble. Okay, bache, clear? Okay. So out of these, iohexol is the one which is commonly used in contrast enhanced CTs. Also, iohexol has a role to play in two more indications: esophageal perforation and myelography. Osmolarity 600 to 800 milliosmol. Non-ionic monomers like iohexol, ioversol, iopamidol are preferred for CECT. Most commonly iohexol. Okay. Also used in esophageal perforation and myelography. My question is for you, beta. Tell me. Baki bowel perforation mein gastrographin was okay. But esophagus mein we are using iohexol. Anybody can tell me the why? Okay, we are at the last page of the class. See, if there is a problem in esophagus and the patient vomits and you aspirate, the dye will go into the lungs. If a high osmolar dye goes into the lung, if high osmolarity dye goes into the lung, what will happen? It will cause water to accumulate in the lung. It will cause pulmonary edema. That is why if there is a problem in esophagus, we don't want to use high osmolar dyes. We can use iohexol. Are you clear? Myelography is, one bacha is saying, what is myelography? Myelography means if you do a lumbar puncture, if I do a lumbar puncture and inject the dye to see the spinal cord, that is called as myelography. Again, non-ionic dye, ionic dye causes inflammation of the nerve roots, arachnoiditis. Here we again prefer iohexol. Okay. Now, one more question. Non-ionic dimer examples: iodixanol, iotrolan, osmolarity 300 milliosmol, isoosmolar to plasma. So, safe in renal insufficiency patients, safe in pheochromocytoma patients. Okay. Now Prachi is saying, sir, bowel perforation mein iohexol kyun nahi use karte? We can use it, but it is very expensive to use. There is no advantage, so we don't use it. Okay. Are you clear, Prachi? And I think Patel Pant is also. So the dyes which are non-ionic will always be more expensive than the ionic ones. So if it is needed, then only we use it. So ionic, non-ionic dimers like iodixanol, iotrolan have an advantage that they have less side effects because their osmolarity is same as plasma. They are safe to use in renal insufficiency. They are safe to use in pheochromocytoma. They do not cause hypertensive crisis. Okay, clear? Now, what side effects some bacha was asking? See, side effects of iodinated contrast can be dose dependent and idiosyncratic. Idiosyncratic side effect is non-IgE mediated histamine release. Okay, I'm again repeating, listen to me. Some patients, idiosyncratic matlab not predictable. can develop a non-IgE mediated histamine release because of iodinated contrast. It is called as anaphylactoid reaction. Life-saving drug, adrenaline. Okay. Esophageal perforation, I told you, Sri Shravan, we use, okay, I will explain this answer, give me 1 second, okay. Dose dependent side effect, Shivam, listen to me, dose dependent side effect is, it will cause tubulointerstitial injury to the kidney, tubulointerstitial damage in the kidney. So, that is why we need a serum creatinine level, because patients with renal insufficiency, dehydration, diabetes, multiple myeloma. If you give iodinated contrast, they are at high risk of nephropathy. Usually self-limiting. Okay, but in patients with renal insufficiency, dehydration, or diabetes, multiple myeloma, it can be an issue. If you see serum creatinine rise more than 0.5 milligram after 42 to 72 hours or 25% above the baseline, you can diagnose contrast mediated nephropathy. To prevent it, you should always make sure any patient undergoing a contrast study should be well hydrated. Okay, Shivam, are you clear now? Okay, why creatinine we know? Because if the patient is having renal insufficiency, iodinated contrast can cause further kidney damage. To prevent it, the patient should be well hydrated. And second prevention is, we prefer non-ionic dimers here. Okay. Now, some children were getting confused. Okay, I'm showing you the entire table in one slide. Okay, are you able to read it now, Shri? Now, one bacha was saying, sir, hum non-ionic dimer kyun nahi use karte? So, always remember, dimer will be more expensive than monomer. Non-ionic will be more expensive than ionic. So that is why I told you ioxaglate, although it is low osmolar, because of the cost, it has no particular MCQ associated with it. Although in MD level I will tell you something else, but not for you, nothing more. But here it is clear that iohexol is better for esophageal perforation, but bowel perforation, otherwise we use gastrographic. Add full forms. Andita, beta, I have written everything in full form only. I am saying rise in serum creatinine more than 0.5 milligram or 25% above the baseline after 48 to 72 hours is nephropathy, usually self-limiting, but can be prevented by hydrating the patient before the study and using non-ionic dimer isoosmolar dyes in high-risk patients. Okay, now, so what I'll do is I will just quickly summarize everything that we have discussed today, although we got a little late in the earlier part, but we will cover everything, don't worry. So what we have done so far is I have taught you what is a CT scan. I have shown you CT anatomy of the brain. We spent a lot of time on it. I have shown you different types of hemorrhages, different type of infarcts. I have shown you aortic dissection, how to identify. I have shown you pulmonary embolism. Okay. And also I have shown you things like 3D CT, dual source CT, which was used in patients with gout and urinary stones. I have shown you a quick image on cardiac CT. I have shown you what is CT angiogram. And also, in addition to all of this, I have shown you what is iodinated contrast. Okay. And don't worry, pulmonary disease, I will spend many hours on chest x-ray and chest CT scan. Don't worry, I will spend a lot of time on pulmonary diseases, TB, COVID, everything. Today my purpose mainly was brain and CT. Okay. Are you clear? Everybody? Now, just to see how much you have understood, what I will do is I will play a quick game with you, which is going to be called as fastest fingers first. Okay, I will play a quick game with you. Let's see if I have the game on my phone or my laptop. Just give me 1 second. Okay, I will just do a quick rapid fire quiz with you. You can tell me the answer and then we can have more discussion. Okay, are you ready to tell me what you have understood in the class today? Are you ready to tell me what you have understood in the class today? Let's try and do a rapid fire. Fastest fingers first. Racing car appearance seen in. Tick, 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 tick. Where did I tell you about that? Racing car sign. Did I say racing car anywhere? Did we race a fast Ferrari in the class? That was tell me, agenesis of corpus callosum. Remember the parallel configuration of lateral ventricle due to bundles of Probst displacing it, making it parallel. Clear? Okay, beta. Second question. EDH can cross the midline, true or false? EDH can cross the midline, true or false? Anybody? And I can see you are rocking the show. Tell me, extradural hematoma can cross the midline, true or false? Tell me. The answer is true. EDH can cross the midline, especially in the frontal area, it can cross the midline. EDH can cross the midline. Subdural hematoma cannot cross. Let's see. Subdural hematoma can cross the tentorium, true or false? Subdural hematoma can cross the tentorium, true or false? Tell me. The answer is false. Subdural hematoma cannot cross the dural folds because it is below the dura. Anywhere you have a dural fold, it will stop the blood from flowing. So SDH cannot cross the tentorium. Okay, are you clear? Okay, so this line is false. Everybody understands? Good. So you can see by the action on the chat box, and now you can understand why initially we had a server issue in the morning, because it's so many people logging in. Because I love teaching live, and I know my children want to study live from me. So everybody together. Investigation of choice for cerebral aneurysm. Anybody tell me? Investigation of choice for cerebral aneurysm. The answer is investigation of choice for cerebral aneurysm. Did we talk about it? Yes, we did. The answer is CT angiogram. CT angiogram. IOC for cerebral aneurysm. CT angiogram. Clear? Very good, beta. Most common site of hypertensive bleed in the brain. Most common site on hypertensive bleed in the brain. Anybody can answer. The answer was putamen. The correct answer is putamen. The correct answer is putamen. Investigation of choice for pulmonary embolism. We saw that on the class. Anybody? Investigation of choice for pulmonary embolism is investigation of choice for pulmonary embolism is CT pulmonary angiography. CTPA. CT pulmonary angiogram. Everybody understands? Clear, beta? Okay. Identify the problem. Okay, this is a same to same image from a NEET PG exam. Now tell me. Identify what has happened. Identify what has happened. This is a NEET PG image. Look at the sulci. Look at the basal cisterns. All the CSF filled subarachnoid space is all white because there is no water there. What is there? Tell me. There is blood there. This is a patient with subarachnoid hemorrhage. SAH. Subarachnoid hemorrhage. SAH. Same image has been asked in the exam. Keep in mind, now you are already good to go. Okay. Identify the problem in this patient. Super excited you are now because you have understood. My goal is to make sure that you understand, don't revise, you will do it right in the exam because you have understood. Understanding is permanent. Okay. Anybody, what is the problem in this CT scan? There is a aortic dissection, but reverse from the class. It is in the descending aorta, not in the ascending. Ascending is normal. Can you see? Ascending is normal. Only in the descending. Stanford type B dissection. Management? Medical management. You will do a medical management in this case. And I can see all of you are rocking the show. If you get all of them correct, do let me know on the Instagram inbox. Okay. One beautiful image just for you. Okay. Because you are the best students I have taught in many years. I'm super excited by your intelligence. So let me give you one image. Can you tell me what investigation is this? This is your aorta and you can see a intima flap, 2 lumen in the aorta. But why is aorta looking so big? Because I have put the echo probe in the esophagus. I am putting it through the transesophageal echocardiogram. Okay. This is what, remember I told you, somebody was saying what is TEE? Transesophageal echocardiogram. If I want to look for aortic dissection, but the patient is hemodynamically unstable, you do a bedside TEE. Is that interesting to see? Beautiful to see? Yes? Okay. Now what I'll do is, I will quickly take out my brain. I will quickly take out my own brain and show it to you so that we can learn together clinically. This is what we saw today, how the cerebellum is, where the pons, this is cerebellum, this is your brain stem, remember? And I can show it to you. Okay, and I will also try to rotate it for you if possible. Okay, now I'm rotating it. Now remember I talked to you about temporal lobe, Sylvian fissure. So on the lateral surface you can see the Sylvian fissure, large fissure that we saw. And we remember below it you have temporal lobe and above it you have the parietal lobe, occipital lobe behind. Okay, clear everybody? So at the end of it, at the end of today, what we have done is I wanted to, actually show you the MRI also, but I thought, I can give you the, CT today because of the delay beyond my control. But I promise you that every class, after every class, you will have more solid concepts. In the next class, I will show you all about MRI. Okay, all about MRI, like I have shown you CT. Gradually, I will spend time on chest X-ray also in length. I will show you bone X-rays also where I think I can add a lot of value. And bariums, IVPs, I will show you a lot of things. After it, nothing will come out of the class from in your exam, but you have to be attentive in the class. Make notes in the class. Anything you feel that is not answered, don't worry. I see a lot of face-to-face students are saying you want to meet me offline. I am again repeating, I will come to every center after the class. After I finish it in small tukra, I will come to your class and again revise the entire radiology for you in one day, and then I will take your doubts also. And plus I will also do it in the every class also. And all my bachas who are from VSAT batches, online batches, I will upload a class test with a video solution for you also. Beta, don't worry. And if you still have any more doubts and you want to talk to me, you can today connect to me on Instagram, send me a message. I will reply to you with an audio message. Even if it is a small thing like you got all of the questions right, you are happy, just let me know. Send me an inbox on Instagram. I will reply with an audio message to the best of my ability. I will try to help you. I love you all. I wish you all the best. It is my pleasure to be able to teach you. I'm so happy that we could do it today. God bless you. Keep rocking. And you are the best batch I have taught in many years. Remember this. Best of luck, everybody.